Subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. Let me begin by welcoming everyone to today's hearing on how reining in pharmacy benefit managers, or PBMs, will drive competition and lower costs for patients. Before I dive into the policy, I want to take a moment to address the true reason why we're having this hearing today, and that is patients. Patients like Matthew. Matthew is a 16-year-old Georgia resident who suffers from a rare genetic disorder. CVS Caremark denied Matthew's access to a life-saving drug that he had been on for 2 years, and as a result of that, Matthew was forced back into the hospital. Let me be clear, PBM's greed sent a 16-year-old back to the hospital in critical condition. While tragic, this story is far from unique. So how did we get here? PBMs are the pharmaceutical supply chain's hidden middlemen that are driving up costs for prescription medications, delaying access to necessary treatments, adding hoops for patients to jump through, and robbing hope from patients. They have only created perverse incentives throughout the drug supply chain. Their extensive market control has only grown due to consolidation and vertical integration, leading to less competition and decreased patient choice. After nearly 2 decades of consolidation, the PBM industry is now dominated by 3 companies that control over 80% of the market. 3 companies that control over 80% of the market. They own or are owned by insurers and have vertically and horizontally consolidated their businesses to own doctors, pharmacies, group purchasing organizations, and more. One of them even owns a bank. We have heard directly from our constituents that the harmful and anti-competitive tactics of some PBMs have only gotten worse and that congressional action is desperately needed. We've heard a constant stream of reports that some PBMs are reimbursing independent pharmacies less than the pharmacies they own. For example, a Mississippi audit revealed that Optum pays its own stores up to 22 times what it pays independent pharmacies for the same drug. How are you supposed to stay in business when your competitor makes 2,200% more than you do for the exact same service? The answer is you don't. Unfortunately, you don't. In 2023, there were over 300 independent pharmacy net closures, almost 1 per day. Unfortunately, that trend continued in 2024. Pharmacists are some of the most accessible and highly trusted healthcare professionals. Yet PBMs are putting pharmacies out of business and removing patients' access to care. We now have pharmacy deserts in rural and underserved communities. That's affecting the accessibility, affordability, and quality of health care for all Americans. As I say all the time, whether you're a Republican, Democrat, or independent, we all want the same thing. We want accessible, affordable, quality health care. Recently, the Federal Trade Commission released its second interim report, which found that PBMs charge significant markups for cancer, HIV, and other critical specialty generic drugs by thousands of percent, and many others by hundreds of percent. Another egregious example of PBM's abuse of taxpayer-funded programs is the United States Postal Service health plan. In an audit released in March of 2024, the Inspector General of the U.S. Office of Personnel Management found that Express Scripts overcharged the health plan and the federal government nearly $45 million. $45 million. Thankfully, President Trump is committed to holding PBMs accountable. I commend him, and I look forward to working with this administration to drive solutions that lower costs for patients at the pharmacy counter. The House Energy and Commerce Committee has made common sense PBM reform policies a bipartisan process. Last Congress, this committee advanced bipartisan legislation that saves significant taxpayer dollars in Medicaid managed care programs, and for the first time in Medicare Part D, enforces reasonable and relevant contract terms that support pharmacies' ability to serve patients in addition to delinking PBM compensation from list price. Further, this committee championed reporting requirements which would increase transparency by shining a light on the opaque drug pricing system that is driving up drug spending for patients and employers in addition to harming pharmacies. Americans deserve and expect protection from inflated prescription drug costs, forced pharmacy closures, and barriers to healthcare access. I look forward to working with my colleagues on both sides of the aisle to enact these meaningful PBM reforms for patients like Matthew who are suffering at the at the expense of PBM's abusive tactics. I want to now recognize the gentlelady from Colorado, Representative DeGette, for 5 minutes for an opening statement.
Thank you so much, Mr. Chairman. And here's something that we can agree on. Republicans and Democrats agree we must rein in PBM abuses. We know how PBMs play games to pad their bottom lines at the expense of consumers. We know how they take money out of state and federal taxpayers' pockets when they charge a Medicaid plan more than a drug they pay for in a pharmacy. This isn't news. I see a number of pharmacists here in the audience, and I want to welcome all of you to our committee hearing. Thank you for being here. You put a face on this for us. So you might be wondering, if we all agree, why haven't we gotten PBM reform signed into law yet? Last Congress, Democrats and Republicans held more than a dozen hearings in committees in the House and Senate, including 3 in this committee to discuss PBMs. So to me, this feels like deja vu all over again. The need to reform the prescription drug system is clear, including cleaning up how PBMs operate and stopping abuses of their market system at the cost of consumers. So that's why this committee passed PBM reforms last Congress, and that's why we took the work this committee did and folded it into December's government funding bill. We were on the brink of passing historic reforms. And then, at the behest of Elon Musk, Republicans balked. So let me be really clear. Donald Trump and Elon Musk ordering congressional Republicans to renege on a bipartisan bicameral agreement is the reason PBM reforms are not law today. This agreement included PBM reforms, but it also included bipartisan wins like reauthorizing and adding new funding to the special diabetes programs, encouraging innovation in pediatric rare disease drugs, and reauthorizing CDC support for maternal mortality review committees. Mr. Chairman, I have here in my hand a 17-page list of the policies that the Democrats and the Republicans in the House and Senate agreed upon last year that have not yet been signed into law because Elon Musk and Donald Trump forced the Republicans to remove them from the continuing resolution last year. And I'd ask unanimous consent to place this in the record.
Without objection.
Thank you. So here we are again. We're just talking in a topical hearing yet again about reforms that we all agree upon, rather than just passing those reforms and moving on to other pressing business. Instead of this reiteration of previous work, this subcommittee could be examining what effect indiscriminate mass layoffs at HHS will have, including slowing down drug and device approvals and hindering our ability to assure the safety of nursing home residents. We could be talking about the threat of avian flu, which grows every day, and what this administration is doing to prevent it from becoming a pandemic, but also getting eggs back on our shelves. We could be talking about the impact gutting Medicaid for working families to pay for tax cuts for the wealthy would have. And we could be looking ahead to oversight of the PBM reforms that should have been law last December. Thousands of my constituents have contacted my office worried about these issues in the last few weeks, and I'm sure everybody in this room has been hearing the same. But the majority knows all these questions that are important to our constituents are embarrassing to the administration, and so we're not talking about them, which is very frustrating to me. So, Mr. Chairman, I want to ask you, if you don't mind, what is the plan of the majority to get that bipartisan plan, including PBM reform, and also all of these other important healthcare extenders that we agreed on last year to the floor?
At this point, we are uncertain whether we're going to, excuse me, at this point, we're uncertain as to exactly what we're going to do, but I can assure you that it will be cleared up soon.
One of my concerns is some of the parts of your PBM bill, some of the important parts will not be burnable in budget reconciliation. And so I think, and you and I have discussed, Mr. Chairman, the idea of bringing up a bill that would be the PBM reform and all of these Medicaid extenders and putting it on suspension. And so I hope you're considering that, Mr. Chairman.
Oh, absolutely. Absolutely.
And as I told you, and I'm going to say this publicly for the record, if you did that, I'm going to guarantee you every Democrat would vote for that on suspension.
Thank you.
So I'm going to urge you to bring it up before March 15th, because that's when these provisions all expire.
Understood. Thank you.
I yield back.
Gentlelady yields. I now recognize the chairman of the full committee, Chairman Guthrie, for 5 minutes for an opening statement.
Thank you, and I appreciate the ranking member's comments on that. You know, to be able to move these outside of reconciliation means we're going to have to work together. We have to do it in a bipartisan way, and hopefully we're going to find that pathway to do it in a bipartisan way. I just want to thank the chairman and the ranking member for this hearing today. Our first health subcommittee hearing was discussed the illicit drug threats ravaging our communities, in particular the continued threat of fentanyl. I'm happy to report that after that hearing concluded, we're able to pass the Halt Fentanyl Act in strong bipartisan support on the House floor. And today we're continuing our fight to lower health care costs for everyday Americans and especially our seniors. Last Congress, the Committee on Energy and Commerce worked to advance legislative solutions to make our health system more transparent. That's what the gentlelady was just referring to empower patients. Because of this work included holding pharmacy benefit managers accountable by making their business practice transparent and passing legislation to cut unnecessary spending on prescription medications in Medicare and Medicaid. As chairman of the full committee, I've heard from many of our members of this committee loud and clear, and I can tell you it is a priority of mine to ensure these common sense and bipartisan policies become law. Today, over 80% of prescription drug benefits are managed by just a few vertically integrated PBMs. As a result, patients have less choice when they fill their prescriptions and oftentimes have less access to affordable prescription medications. Data shows pharmacies that are not affiliated with the largest PBMs are frequently reimbursed less than their affiliated competitors. I remain concerned by PBMs using their market power to hurt our independent pharmacies and restrict patients' access to pharmacies. I want to remind members of the committee that over 26,000 local retail and community pharmacies have closed in the past 15 years. The Government Accountability Office recently studied how the current system of rebate negotiation is working for Medicare beneficiaries. They characterized the problem by stating that rebates do not lower beneficiary payments, and that higher cost drugs generally result in higher beneficiary payments. In GAO's analysis of the top 100 most highly rebated drugs in Medicare, for 79 of these out of 100, seniors ultimately paid substantially more than their Part D plans paid for the drugs. Today, I hope we're able to come together again and focus on our bipartisan solutions to rein in spending at the pharmacy counter for America's families. I appreciate the Health Subcommittee for holding this hearing, and I will yield the remainder of my time to Vice Chair, my friend from Florida, Mr. Dunn. Dr. Dunn.
Thank you very much, Mr. Chairman. Let me just say thank you to our witnesses for being here today. It's apparent to me that the PBM reform is ripe to address. Last Congress, this subcommittee did excellent work to advance policies that would shed light on the inner workings of PBMs and provide transparency into their practices. Prohibiting spread pricing in Medicaid and delinking PBM compensation from the list price of drugs are simply common sense reforms that I'm confident enjoy bipartisan support, as you've heard today. I'm excited to continue that work and thank Chairman Carter for his commitment to ensuring that the PBM reform remains a priority for this subcommittee. With that, I yield back.
Gentleman yields. I now recognize the ranking member of the full committee, my friend from New Jersey, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Chairman Carter. Today, committee Republicans are holding a hearing on pharmacy benefit managers, PBMs. At the same time, they're trying to take health care away from millions of Americans. Bottom line is if people don't have health care, they're not going to get drugs at all, and PBM reform won't even matter to them. Republicans continue to push a budget resolution that would direct this committee to cut at least $880 billion from programs within this committee's jurisdiction. And we all know the vast majority of these cuts will come out of the Medicaid program. Republicans are also hiding the true price tag of their Medicaid cuts. Since their budget resolution is over 9 years rather than 10 now, the size of the Medicaid cuts will actually be closer to $1 trillion over 10 years. And that is hundreds of billions of dollars more than an entire year of federal Medicaid funding. And we have the Freedom Caucus demanding that the House find an additional $500 billion in spending cuts, which will almost certainly come from Medicaid if they prevail. Now, once again, Republicans are showing they are willing to rip health care coverage out of the hands of everyday Americans to provide tax cuts to Elon Musk and his billionaire friends. The people who will suffer are children, seniors, and people with disabilities, pregnant women, and families trying to get by. The shocking part is that many of these people live in Republican districts. For instance, Representative Obernolte has one of the highest percentages of Medicaid beneficiaries in the country, with 47% of the people living in his district relying on Medicaid. Over 31% of the good people living in Chair Guthrie's district rely on Medicaid as a vital lifeline, with 42% of kids in his district relying on Medicaid and CHIP. Now, Republicans will claim that they want to cut the Medicaid program because they want to address fraud, waste, and abuse, and that no one's going to get hurt. But that's absurd. You simply cannot take that amount of money out of the Medicaid program and not hurt the people who rely on it. Medicaid is, in fact, a lean program. Despite picking up the tab for cost of care that no other payer covers, per-person spending is a fraction of the cost of private insurance or even Medicare. The reality is that gutting state Medicaid budgets will lead to fewer people with coverage, fewer benefits for the people who manage to keep their coverage, worse access to care, higher health care costs for everyone, and more medical debt. And hospitals and community health centers will be forced to close. And Republicans are turning their backs on the American people to hand out giant tax breaks to their billionaire friends. Now, turning to the topic of PBMs, I believe we should be working together to bring greater transparency to PBM practices so we can lower the cost of prescription drugs for consumers. Increasing transparency of PBM practices can help employers, consumers, and the American people better understand how drug prices are ultimately determined at the pharmacy counter. Last December, we had a bipartisan, bicameral agreement on a number of policies to reform PBMs and to address the lack of transparency within the market. But, as you know, Speaker Johnson reneged on the agreement after Elon Musk voiced his opposition to it. The agreement he walked away from would have helped lower prescription drugs for consumers, rein in abusive practices that lead to higher drug costs, and help employers better understand drug price information in order to effectively reduce healthcare costs. The package also included a number of other critical components, such as funding for community health centers, teaching health centers, and 2 years of telehealth and Medicare. But again, at Elon Musk's direction, House Republicans pulled the bipartisan agreement, leaving these important bipartisan solutions on the cutting room floor. And now we're 2 weeks away from the continuing resolution expiring. And my Chairman Carter, who I respect, says he's going to have a plan soon to bring up the package with the PBMs again. But I have to be honest, I'm only going to believe it when I see it, right? It's more likely, in my opinion, that you have some plan and Elon Musk just waves the magic Musk wand once again, and that's the end of PBM reform. I might sound cynical, but I saw it happen, and I see it every day with Musk, and that's what I think is going to happen, but we're ready with you to work on PBM reform and try to pass this entire package again. But I'll believe it when I see it. And with that, Mr. Chairman, I yield back the balance of my time.
The gentleman yields. This concludes member opening statements. The chair would like to remind members that pursuant to committee rules, all members' opening statements will be made part of the record. We want to thank all of our witnesses for being here today and taking the time to testify before the subcommittee. Our witnesses today are, first of all, my good friend, Mr. Hugh Chancey, a pharmacist in honor of Chancey Drugs. Mr. Sean Grimminger, is that okay? Grimminger. Okay, Grimminger, everybody. Mr. Sean Grimminger, a president and CEO of the National Alliance of Healthcare Purchaser Coalitions. Mr. Anthony Wright, Executive Director of Families USA, and Dr. Matthew Fiedler, Senior Fellow in Economic Studies at the Brookings Institute on the Center on Health Policy. Thank all of you for being here today. Per committee custom, each witness will have the opportunity for a 5-minute opening statement, followed by a round of questions from members. The light on the timer in front of you will turn from green to yellow when you have 1 minute left. I now recognize Mr. Chancey for 5 minutes to give an opening statement.
Chairman Guthrie, Ranking Member Pallone, Subcommittee Chairman Carter, Vice Chairman Dunn, Ranking Member DeGette, and members of the committee. My name is Hugh Chansey. I'm a pharmacist and co-owner of Chansey Drugs and a former president of the National Community Pharmacists Association. I greatly appreciate the opportunity to share with you my experience as a pharmacist and a small business pharmacy owner about how PBMs have negatively impacted my ability to care for my community. My family has been in the pharmacy services in South Georgia since 1966, when my father, Hubert Chansey, opened our original Chansey Drugs location. Chansey Drugs specializes in compounding, in specialty packaging, and enhanced clinical services, and we employ over 100 people. I'm proud of the work that Chansey Drugs has done over the decades, offering essential health care to patients, but this important work is being jeopardized by the PBMs that determine which patients have access to our pharmacy, the prices that they pay, and with reimbursement pharmacies receive, and the medications that are on formulary. The top 3 PBMs control over 80% of the market. Due to vertical integration, they steer patients to their own affiliate pharmacies. Many patients who are required to use PBM-owned mail order pharmacy receive their medications late or sometimes not at all. Recent reports from the Federal Trade Commission found PBMs steer patients to use specialty drugs at their affiliated pharmacies, allowing the PBMs to generate more than $7.3 billion in revenue. PBMs are also engaging in anti-competitive tactics like cost inflation, spread pricing, low pharmacy reimbursements, coercive contracts for non-affiliated pharmacies, leading to higher costs for government, limited patient choices, and increasing pharmacy deserts. PBMs claim that they save money for the state-funded health plans like Medicaid managed care, yet numerous reports show something very different. Excessive amounts of taxpayer dollars funneled to PBMs. Eliminating spread pricing and moving to a transparent, cost-based reimbursement saved West Virginia and North Dakota $54.4 million and $17 million, respectively, in their Medicaid program. Kentucky identified $123 million of spread pricing annually, precipitating a wholesale change to their Medicaid pharmacy model. Meanwhile, Ohio's Auditor General found over $224 million of spread pricing. Likewise, Illinois, Virginia, and Maryland have all found egregious sums of spread pricing in their states. Do you see a theme? That's why Congress must pass Medicaid managed care pharmacy payment reform and ban spread pricing by requiring 100% pass-through to the pharmacy of the ingredient cost and the professional dispensing fee, which the CBO has scored a savings of $2 billion. On top of this, our contracts with PBMs are take it or leave it. Especially in Medicare Part D, pharmacists are not able to negotiate better terms in our contracts, in direct opposition to what the PBMs have sworn in Congress. Some of the most basic yet most life-sustaining medications are often under-reimbursed, and we are rarely paid for the actual cost to dispense. Georgia's professional dispensing fee for Medicaid pays $10.63, but it's not unusual for me to get paid only a nickel and oftentimes receive no dispensing fee at all for Part D patients. In addition to the Medicaid managed care reform, I support the legislative provision requiring reasonable and relevant contracts between PBMs and pharmacies in Medicare Part D, quelling PBM exploitation. Both policies were included in the negotiated health care package at the end of last year. Altogether, the PBM reform policies included in that package saved nearly $5 billion and are a huge step forward in protecting pharmacists and patients from PBM greed. It is critical these bipartisan bicameral policies get passed and as quickly as possible. Because of the PBMs, we have lost nearly 2,700 retail pharmacies in the last 4 years. If the PBM industry continues to go unchecked, thousands more, like Chansey Drugs, could go out of business, further reducing access and increasing cost. In conclusion, I want to end with a personal story that gets to the heart of independent pharmacy. My community was devastated by Hurricane Helene, and our town was without power for days. In this time, my pharmacy in Valdosta served as a disaster relief hub to collect and deliver vital supplies like water, baby wipes, formula, and toiletries. Now you tell me, can a PBM do that? I implore you to take immediate action and pass common sense legislation to rein in harmful PBM practices to pharmacies and patients alike. We are not asking for favorable treatment. We're asking for a level playing field. I encourage lawmakers on both sides to continue to work in bipartisan manner to pass these reforms that save $5 billion. If not, we will see more deserts, pharmacy deserts, and less access to care. I applaud this committee for its bipartisan efforts to shine light on the PBMs, and I am happy to answer any questions. Thank you.
Thank you, Mr. Chansey. Chair now recognizes Mr. Grimminger for 5 minutes.
Thank you, Chairman Carter, Ranking Member DeGette, and members of the subcommittee. It's an honor to speak to you today on behalf of the National Alliance of Healthcare Purchaser Coalitions. We're the voice for more than 40 regional and local purchaser coalitions, which together represent employers, private companies, public entities, labor union trust funds, and others, covering more than 45 million covered Americans. I'm here to provide the perspective of self-funded employers and purchasers on the immediate and pressing need for PBM reform. In particular, I'm here to voice our strong support for Sections 901 and 902 of Title IX of H.R. 10445, the original version of the continuing resolution released in December. Those two provisions provide for real from the initial purchase of the drug by their wholly owned GPO all the way down to the sale to the final purchaser. Over 100 million people receive their health care through self-funded employer health plans governed under ERISA. Self-funded employers directly contract with PBMs to manage their pharmacy benefit. Given that self-funded employers directly pay for the costs of their pharmacy and medical benefits and hold the risk of variation in plan spending, employers essentially hand PBMs their credit card and say, go out and spend our money wisely. Since ERISA's creation in 1974, self-insured employers and purchasers have been held to a fiduciary standard to oversee plan assets set aside by their employer on behalf of covered individuals. The Consolidated Appropriations Act of 2020 raises the bar for self-funded health plans, requiring them to pay fair prices for goods and services. Unfortunately, over the past several decades, the PBM market has become highly dysfunctional to the detriment of employers, purchasers, and working families. I want to focus on two key market distortions: wasteful formulary placement and deeply rooted opacity. While clearly against the best interests of employers, purchasers, and patients, PBMs will often place drugs with limited clinical value and higher net costs at preferred tiers on an employer's formulary. Wasteful formulary placement occurs when a PBM is able to extract higher discounts or fees, not passed on to employers, from manufacturers seeking to expand market to the overpriced or low-value drug. Section 901 of the bill in front of you requires PBMs to disclose and provide a rationale for formulary placement and disclose when formularies are changed. Perhaps the most pernicious flaw in the PBM market is the level of opacity between PBMs and their plan sponsor clients. In general, plan sponsors are unable to determine the initial price of a drug paid by the GPO, the extent to which negotiated rebates are passed on to them, and whether there is a differential in pricing between wholly owned pharmacies and those by other entities. Section 901 provides vital information to employers to answer those key questions. Let me say this very clearly. Most self-funded employers, to this day, do not know how much money they are spending on any specific drug. Given that, how can employers act as prudent fiduciaries under ERISA? I want to give you a specific example of one of the challenges employers face. Earlier this week, I spoke to the benefits leader of a large self-funded plan with more than 200,000 covered lives. They are currently conducting an RFP on a new PBM. This benefit leader asked the applicant PBMs if they would be willing to provide claims-level rebate information. All of the big PBMs refused to do so. The legislation before you would mandate it. Before I end, I want to address some of the claims you'll hear from the big PBMs. The PBM industry will tell you that employers are happy with their vendors and don't want reforms. If that's the case, I'll ask you why 89% of the employers in the National Alliance survey of 188 large and mid-market employers said they support PBM reform. If employers are happy with their PBMs, then why are the nation's leading employer representatives, ourselves, the ERISA Industry Committee, the American Benefits Council, the HR Policy Association, and many others, on record supporting this legislation? The PBM industry will tell you that employers are able to engage in real negotiations with employers to design their contracts the way they want them. If so, then why is one of the largest, most sophisticated, most aggressive purchasers in our network unable to get answers to a simple question: how much am I paying for each drug? The PBMs will tell you they already pass on all or nearly all rebates and discounts. If so, then why are they so dogged in opposing a bill mandating they do what they already claim to do? There's a reason that big PBMs are willing to make false claims to you. They cannot stand the thought of a functional market in which empowered employers and purchasers can demand better prices. The legislation before you represents the most significant reform to the PBM industry in history. It is fundamentally rooted in establishing a more transparent, freer, fairer market. The big PBMs will do everything in their power to stop that from happening. Thank you again for holding this hearing, and I look forward to your questions.
Thank you, Mr. Grimminger. Chair now recognizes Mr. Wright for 5 minutes for an opening statement.
Thank you. Chairman Guthrie and Carter, Ranking Members Pallone and DeGette, on behalf of Families USA, the longtime healthcare consumer advocate, thank you for the opportunity to discuss the need for transparency and oversight of pharmacy benefit managers as part of broader efforts to advance affordability and access for families seeking life-saving medications and care. In last year's election, Americans made it clear their concerns about costs. And while they've talked about the price of eggs for months, they've been screaming about the price of prescription drugs and health care for decades. Nearly 3 in 10 adults report rationing, skipping doses, or not filling their prescriptions at all because they can't afford it. An estimated 125,000 people die each year as a result of not taking their medications as prescribed, in part due to cost. Inflated prescription drug prices affect everyone as they contribute to rising insurance premiums, higher deductibles, and stagnant wages for workers. Drug companies seek to shift the scrutiny and blame, but ultimately they are the ones who take advantage of our system to set high initial prices and then routinely increase them far faster than inflation. To counter these ever-increasing costs, Congress should continue its bipartisan efforts to stop the gaming of patents and also to protect and expand Medicare's ability to negotiate drug prices. In the absence of broader government regulation or negotiation of drug prices, payers like insurers, employers, and union trusts turn to pharmacy benefit managers as an important tool to help them bargain for the best value. Yet the PBM solution has sometimes become part of the problem, building a business model where their own revenue depends on high drug prices. Many of these middlemen's operations are opaque. As was stated, not even employers who hire PBMs know the actual drug prices they are paying or what rebates the PBMs are receiving. This leaves patients and plans wondering if the PBMs are negotiating for the best cost, quality, and value of the prescription drugs, or just simply try to rake the most money off the top. These issues get bigger as mergers lead to more consolidation of PBMs, insurers, and pharmacies. As was stated by the chair, now the top 3 PBMs control 80% of the market, making it less competitive, allowing prices to rise, undercutting independent pharmacies, reducing patient choice, and access for families in many rural and underserved communities. This impacts people like my mom, who until her passing recently was a diabetic and breast cancer survivor who took 10 different drugs, not unlike many seniors with a burgeoning bill. She benefited from a small pharmacy around the corner from her home in the Bronx, glad not to have to trek to the chain store in the next neighborhood over. I was grateful for that community pharmacist who sometimes checked in on her and hand-delivered her medications. But such options are unfairly undercut by PBMs seeking to steer patients to not necessarily the most affordable or convenient choice, which might make sense, but to the big chain that they own. Families USA recommends that this committee take action to address PBM abuses and reduce prices in 4 ways. 1, require greater transparency of PBM negotiations, their operations, and their ownership structure. 2, increase oversight and regulation of PBM consolidation at the FTC and other agencies. 3, explore ways to eliminate perverse incentives for PBMs to prioritize higher priced drugs. And 4, seek to ensure all savings paid to PBMs are passed through to payers and consumers. We strongly support PBM reform as part of the broader affordability agenda on drug prices and healthcare costs. However, we must also convey the context that any benefits of PBM reform would be exponentially overwhelmed by negative impacts of massive Medicaid cuts that this Congress is currently considering, from the loss of coverage to health impacts to increasing costs. The uninsured don't have a PBM or a plan or anyone to negotiate drug discounts. As a result, the uninsured pay more for prescription drugs than anyone else in the entire world and are twice as likely to forego meds as those with Medicaid coverage. And that neighborhood pharmacist in the Bronx, who might be undercut by PBM practices, may likely go under if Medicaid faces major cuts as contemplated. and that would be true in rural areas as well. Rather than taking a chainsaw to healthcare programs, the PBM policies discussed today represent a careful, common sense, and consumer-oriented approach and would yield some initial savings and provide transparency to inform further reform. Like the laudable Lower Cost, More Transparency Act in the last Congress that this committee worked on, PBM reform is a way that policymakers can work together to advance well-vetted bipartisan reforms to the healthcare system that improve transparency, fix misaligned financial incentives, and lower the cost for the American people and the federal government. Americans are asking policymakers to make care more affordable, not less. PBM reform can and should be passed as part of a broader affordability agenda to provide real relief on healthcare costs that Americans are demanding. Thank you for your time and for holding this hearing.
Thank you, Mr. Wright. Chair now recognizes Dr. Fiedler for 5 minutes for an opening statement.
Chairman Carter, Ranking Member DeGette, and members of the subcommittee, my name is Matthew Fiedler, and I'm a health economist and a senior fellow at the Brookings Institution. I'm grateful to be here to discuss how the market for PBM services is working, as well as the potential and limits of recent reform proposals. A core problem with the PBM market is that competition is weak. By some estimates, the 3 largest PBMs control almost 4/5 of the market. Various frictions in this market also dampen competition. The complexity of the contracts between PBMs and their clients, who may be insurers or self-insured employers, can make comparison shopping hard. This may be particularly true for self-insured employers, whose core expertise typically lies outside of healthcare. Switching PBMs is also challenging, since it requires a plan's enrollees to adapt to new formulary rules and pharmacy networks. As a result, PBMs wield market power that they can use to demand prices in excess of their costs of delivering services and, in turn, earn excessive profits. One way that policymakers have considered addressing this problem is by requiring PBMs to give their clients additional information about how the plans they manage are operating. Greater transparency would likely reduce the price of PBM services by making it easier for payers to comparison shop, enforce existing contracts, or press their PBMs for better terms. It is important to recognize, however, that the savings would likely be relatively modest. The Congressional Budget Office has estimated that transparency provisions, like the ones this committee considered last year, would reduce PBM revenue by around $900 million per year, with that effect fading over time. As a comparison point, PBM's pre-tax profits total about $18 billion in 2022. Another strategy that policymakers have considered is changing how payers compensate PBMs, such as by barring PBMs from retaining manufacturer rebates, delinking PBM compensation from drug prices, or prohibiting PBMs from using spread pricing. Importantly, these types of restrictions are unlikely to directly reduce the price of PBM services. Barring PBMs from collecting certain forms of compensation, such as manufacturer rebates, would likely just lead PBMs to collect more compensation in other forms, such as administrative fees. Changing the structure of PBM payer contracts could affect payers by changing how PBMs manage the underlying drug benefit, although these effects could be both positive and negative. Consider, as an example, barring PBMs from retaining rebates. This change would eliminate PBMs' incentives to prefer drugs with large rebates over the drugs with the lowest net prices when they construct formularies, which would reduce drug spending. But it could also reduce PBMs' incentives to negotiate aggressively for larger rebates, which could increase spending. Delinking and spread pricing proposals can present similar trade-offs. Before I move on, I want to make 2 caveats. First, even where reforming PBMs, how PBMs are compensated, doesn't benefit payers, it might still benefit whoever ultimately pays a plan's premium via interactions with medical loss ratio requirements. But this would depend on the circumstances and on how payers adjusted to the new rules. Second, reforming PBM payer relationships is unlikely to have much effect at all in settings where the PBM and the payer are part of the same company. Notably, that's now the typical scenario outside the self-insured employer market. In closing, I want to make one broader point. If the goal is to make prescription drug coverage cost less or work better, PBM reform is one piece of the puzzle, but it may not be the most important one. PBM profits amount to only several % of overall drug spending, so even eliminating those profits would only moderately reduce the overall cost of drug coverage. If policymakers want to achieve larger cost reductions, that would require reducing the prices received by other actors in the supply chain, especially drug manufacturers. Policymakers may also be concerned that high cost sharing and onerous utilization management protocols make it hard for patients to get the drugs they need. But where this occurs, that's often not because PBMs are failing payers, but instead because payers' incentives are poorly aligned with patients' interests. This may be because payers have incentives to avoid high-cost enrollees, or because it can be hard for consumers to assess a health plan's quality when they pick a plan or choose an employer, or for other reasons. But addressing these types of problems requires reforms to how insurance markets operate, such as improvements to risk adjustment systems or direct regulation of plan benefits, not reforms to PBM payer relationships. Thank you again for the opportunity to testify. I look forward to your questions.
Thank you, Dr. Fiedler. I thank all of you for your testimony today. We'll now begin questioning, and I recognize myself for 5 minutes. Let me begin by asking unanimous consent to submit letters from organizations representing patients, providers, pharmacists, small businesses, and advocates in support of PBM reform. No objection. Without objection. The big three PBMs, vertical integration with health insurance conglomerates, enables them to exploit conflicts of interest to drive prices up, quality down, and independent pharmacies out of business. For instance, the top three PBMs steer patients and the most lucrative prescriptions to their affiliated pharmacies and away from independent competitors. The FTC's latest interim staff report on PBMs found that the big three reimbursed their affiliated pharmacies by up to 7,736% more for specialty generic drugs compared with independent competitors. Unbelievable. Take the drug pirfenidone, for example. It can be purchased without insurance for $200. However, seniors on Medicare filled pirfenidone 85,000 times in 2022 at an average cost of $8,000 per prescription. You can buy it for $200. They were charging $8,000 per prescription. 85,000 times they did that. If you do the math on that, you see that as a big number. Mr. Chancey, I want to start with you. After all, like you, I stood behind that pharmacy counter for many years, and I was the one who had to tell the patient how much the medication was. I was the one who watched a senior citizen try to make a decision between buying groceries and buying drugs. I was the one who watched the mother in tears as she tried to figure out how she was going to pay for her child's medication, and you do that as well. I want to hear from the person that's standing behind the pharmacy counter, like yourself. Can you highlight other areas of inefficiencies in our healthcare system where PBMs have impacted independent pharmacies and therefore harmed patient care?
Yes, there's several things that come to mind. One of the things that they're doing now is they're requiring brand when there's a generic available, and they're making Part D recipients pay the brand copay. Another area, they're controlling access to the pharmacy. We have one patient. She's 92 years old, and her husband is 95, and they're blind. She's legally blind, and we do specialty packaging so that she knows what time to take her dose and her meds, and she wants to be as independent as possible because she's afraid that her husband's going to die and she's going to be left alone. Well, TRICARE actually took that away from us. They narrowed the network, removed us from it, and now they're making him drive like 20 minutes to a pharmacy when he's 95. So we were giving them a great deal of health care, and they took that opportunity away from us and put it to one of the big box chains. But the unfortunate thing is, this is a patient that needed care. I think there's also a waste that we see in mail order. As you've already mentioned, we had one patient that we were filling specialty drugs. They demanded it go to mail order. We later found out that mail order was charging $300 over what they were paying us. I had a colleague that reached out to me with some information yesterday, and this is still bothering me. His pharmacy got turned on to a mail order reimbursement rate in the 1st of January this year. So we compared the first 6 weeks of this year with the first 6 weeks of last year, and on average, he was getting 17 times more profit on the mail order pharmacy reimbursement. You know, that's something you hope that's not right, but it is, because it's proven by the FTC and also by the 3-axis study in Washington State.
Well, thank you for that, and thank you for that information. These are real people. These are real examples that you deal with every day, and we thank you for that. You know, I want to tell you about my Drug Transparency and Medicaid Act. That's part of the original continuing resolution that you had mentioned, Representative DeGette. in December that includes a ban to prevent PBMs from retaining revenue from spread pricing. So are you familiar with spread pricing, Mr. Chancey? Can you talk about that for just a second?
Yes, I am. I think that it's really interesting, and I still don't understand it, why they actually pay pay the chains more than they pay us, and then they pay themselves more than they pay the chains. But recently, I think it was in January, we had a lady, her insurance rolled over into a new plan, but she didn't tell us, so we filled it on her old plan, and she was charged $135. Her insurance paid $135 on her plan. Well, a few weeks later, she gets a bill from the PBM saying that she owes $400. And so our pharmacist said, well, we only got paid $135. So she got on a three-way call with the pharmacist and the PBM, and they said, well, you owe $400. And she said, the pharmacist said, well, you only paid us $135. And well, this is what the plan got charged. So that's spread pricing. $135 is what it costs to get the prescription. $400 is what the plan paid.
Thank you, Mr. Chancey, for that testimony. At this time, I recognize the ranking member, Representative DeGette, for 5 minutes of questioning.
Thank you so much, Mr. Chairman, and I want to thank all of our witnesses for coming today. Mr. Chancey, I hear very similar stories from my community pharmacists in Colorado, and I'll just say the reason why they're forcing people to go to the chains is because in many cases they own the chains, so they can get more money. I want to talk with you for a minute, Mr. Wright, about some of the things that you mentioned, because last Congress, we really worked, and now our first hearing in this subcommittee, it's on PBM reform, because we're trying to make reforms that will make a difference in people's lives. But these reforms are only going to work for people who have health care coverage. And so I made up a little chart, and the chart I made up shows that Republicans who are on this subcommittee have 3,359,524 people in their districts who are on Medicaid right now. And so I want to ask you, Mr. Wright, do you know how many people nationally are covered under the ACA's Medicaid expansion option?
Roughly around 21 million.
21 million. Now, what would happen if those folks didn't have Medicaid, if the expansion was eliminated? What would happen to those folks' ability to afford insurance?
I mean, by definition, the folks that we're talking about make less than $22,000 as an individual, $44,000 as a family of four, and so private coverage would largely be dramatically unaffordable for them. They would become uninsured, and as a result, live sicker, die younger, be one emergency away from financial ruin, both health and economic
So
consequences.
these people make less than $22,000 a year, you said, right?
As an individual, more.
And so if they didn't have either private insurance because they couldn't afford it or Medicaid, what would that do to their prescription drug costs if they had to just buy it without insurance?
They would be paying the rack rate, the list price, which often is the most expensive price in the world.
Do you have an example?
And hundreds or thousands, I mean, if you're an MS patient, those drugs cost tens of thousands of dollars. If you're like my mom who had a list of 10 drugs, that adds up real quick. And
Like to what? I mean, give me an example.
It depends on the person, but hundreds or thousands of dollars. And as I said, the people who are uninsured take their drugs, adhere to their drugs less than half of what people on Medicaid do.
Yeah, I'm the co-chair of the Diabetes Caucus with Congressman Bilirakis, and it's the same thing with insulin. If people have insurance or Medicaid, then their insulin is covered, but if they have to pay private costs, it could be $300 or $400 a bottle, and they die if they don't take it. Now, yesterday, my colleagues on the other side said it's not fair for the federal government to pick up a greater part of the tab for the expansion population than for other Medicaid-eligible individuals. But so what would happen if the government ended that commitment to the current federal assistance for the Medicaid expansion?
If the federal government reduced how much its share of any population, and there's lots of populations that are at different match rates depending on state, depending on aid category. But that is just basically a cut to the state, and then the state basically has to make a Sophie's choice about whether they raise taxes or cut services.
But what if you have a state like Colorado that constitutionally precludes us from raising taxes?
Exactly, and so then you are in a choice, and I was a state health and consumer advocate for 3 decades, and there is no other choice. You either, in healthcare, you either cut people, you cut benefits, or you cut provider rates, and
Okay, I have
have
one,
that impact.
I want you to talk about one last thing, because we keep hearing that the way we're going to save $880 billion is we're going to cut waste, fraud, and abuse. So I want you to talk about how much fraud there is in Medicaid.
I mean, it's a very lean program, probably your best bang for buck within the healthcare system. In terms of beneficiary fraud, it's been estimated at less than 1/10 of 1%.
So does that equal $880 billion?
No.
What is roughly that?
I mean, it would be fractional, and again, that's not. There's other ways to get at fraud, but $880 billion requires massive cuts to coverage, to benefits, and to direct payments to providers.
Thank you. I yield back.
Gentlelady yields back, and Chairman Guthrie, the full committee is recognized.
Yeah, he said beneficiary waste and fraud. Doesn't mean provider waste and fraud. We give a lot of examples of that, and someone doesn't understand that you don't have to cut those kind of benefits. That's not an accurate statement. So I'll start with Mr. Grimminger. Much of the conversation on PBMs has been focused on the rebate model, and I question whether this model creates perverse pricing incentives. Do you believe this model has the unintended consequence of artificially inflating the cost of prescription medications?
Unquestionably. The rebate model, which is sort of deeply embedded in the way that we pay for drugs in the United States, provides all the incentives toward higher list prices and higher overall prices, and very little incentive to actually creating a lower list price and lower rebates. Ultimately, I think, this would be very challenging, but ultimately I think we need to actually move completely away from a rebate model in which we are paying a set price, not a government set price, but a market-based price on a drug that's based on its clinical value over what else is in the market, as opposed to something that incentivizes very high list and then large rebates to try to get onto formularies.
Okay, thank you. And how can PBM transparency legislation this committee marked up? How can the PBM transparency legislation this committee marked up and pass the House of Representatives lest Congress help patients?
Yeah, it's going to allow employers for the first time to actually understand exactly how much they're paying for each drug, right? So right now we have no idea. At this point, there's one of the big concerns in the PBM industry is we only have 3 big ones that represent 75-80% of the market. They often have pretty similar offerings. But the biggest problem is we can't even tell, if you can't tell how much you're paying for each drug, you can't tell which PBM is better for you. You can't tell what other model is better for you. The kind of transparency that we're going to be able to see is going to give us a better indication of where we're getting real value and where we're not. It's going to give us a better idea of whether there are alternative PBM models or alternative contracts that employers can drive toward. It's going to actually create something closer to a fair market, which we believe will actually reduce ultimately the price of drugs. Mr. Fiedler made the suggestion that this particular bill would have a sort of marginal impact on the overall price of drugs. I actually think the CBO and economists are underestimating what the impact could be, because you're going to start creating real competition in a market that really lacks any now, which we think actually will end up reducing the overall price of drugs, because PBMs will actually start competing on getting better deals rather than competing on getting bigger rebates.
Thank you. Mr. Chancey, the Government Accountability Office recently found that 79 of the most highly rebated drugs in Medicare, seniors are required to pay more out of pocket by more than $15 billion than their plan sponsors for these drugs. How do you believe that the legislation to delink PBM compensation from list price in Medicare Part D can help to alleviate the pressure seniors are facing resulting from the current rebate model?
Well, I think through transparency, we're able to follow the numbers and realize where the waste is. I think that's going to help us to bring those prices back down.
But the delinking, do you think that the delinking PBM compensation from the list price, how's that going to specifically help?
I'm not sure.
Okay. In some cases, Mr. Chancey, a generic medication is placed on a specialty drug tier. Does this mean that the generic medication is more clinically effective than a branded competitor?
No.
And if not, what are the implications of this generic medication being placed on a specialty tier from the perspective of patient cost sharing?
That's a good question. It's not always clear why it's done.
Do you think there's a difference?
No.
So thank you on that. And on that, and so if you talk about, we had some questions on Medicaid, so waste, fraud, and abuse. Sometimes, it's not always fraud. Sometimes our system allows systems to move. This is not quite specifically to you, but people seem to think that it's just less than 0.1% that people maybe, if you say fraud, then you have providers that we know that have fraud. And so it's not fraud, but is it waste or abuse if a state, and I was in state government before, and we tried to figured out ways to match the federal match by taxing providers, getting the federal match and giving it back to them. 1% of that is $55 billion. So we're not talking about small money, and we're talking about drawing down the federal government. So when everybody thinks it's just, we're not talking about small numbers, and there's opportunities to take care of waste, fraud, and abuse in Medicaid. And I think we all should want to take care of waste, fraud, and abuse in Medicaid. So I will yield back. Thank you.
Gentleman yields. The chair now recognizes the ranking member of the full committee, Representative Pallone, for 5 minutes of questioning.
Thank you, Chairman Carter. I'm obviously deeply concerned about the Medicaid cuts that Republicans are considering. And yesterday at our oversight plan markup, I repeatedly heard Republicans on the committee refer to so-called waste, fraud, and abuse in Medicaid. Chairman Guthrie just mentioned it, actually. But as they provide this misinformation, which I think is what it is, Republicans are seemingly trying to convince even themselves that they can somehow cut $1 trillion from Medicaid and the American people won't suffer. That's just not the case. And I want to stress to everybody, and maybe to the public, you can't just say, oh, we're going to cut waste, fraud, and abuse, and that's going to save us $880 trillion, right? You have to actually get into what you're going to do. You have to say, I'm going to cut back on 90% for Medicaid expansion. I'm going to reduce the FMAP. I'm going to do X, Y, and Z. You just can't say, oh, we'll cut waste, fraud, and abuse. When they actually do the bill, they're going to have to say what they're cutting. So in the many proposals on the House Budget Committee's list of options, this is for Dr. Fiedler, if you will. On the many proposals on the House Budget Committee's list of options to cut Medicaid funding, do any of these Medicaid proposals, like the chairman's per capita or the other things I mentioned with FMAP, do any of those things, if you just do those things, actually cut down on actual waste, fraud, or abuse?
In my view, these types of proposals are not targeting fraud and abuse. There are broad changes in who's eligible for Medicaid or how costs are shared between the federal government and the states, not proposals aimed at targeting particular problematic expenditures. What's wasteful is ultimately a value judgment, but the policies being targeted, federal support for Medicaid expansion, policy changes that make it easier for low-income seniors to get help paying their Medicare premiums or support for Medicaid generally are, in my view, fairly high-value use of public dollars.
So, Dr. Fiedler, if they do cut the matching rate to states for Medicaid expansion or just the FMAT, for states, even for regular Medicaid, what's the effect of that? How's that going to impact state budgets, for example?
So if you take this specific example of expansion, if the enhanced match for expansion were to go away, the current expansion states would need to come up with $40 to $50 billion a year to fill in that budget hole. And so the question is, what are they going to do? In principle, states could raise taxes. They could cut other spending. Education is typically the largest line item in state budgets, but transportation, public safety, those things could be on the table. But in practice, my expectation is many states would conclude they can't make the math work, and instead they would conclude they have to drop expansion. The expansion population is 14 million people, so it's hard to imagine that we aren't talking at the end of this about many million people becoming uninsured.
Well, thank you. And let me go to Mr. Wright. Can you describe who is covered by the Affordable Care Act's Medicaid expansion? For example, how does Medicaid expansion support parents and families? How does losing health coverage affect the health and economic security of these families? And I guess, well, let me ask you that, and then the next question I'll get to.
I mean, the AC expansion allowed for basically every American under 133% of the poverty level, again, that $22,000 a year, $44,000 for a family of four, to be able to access basic coverage, primary preventative care. It includes parents, it was a patchwork before, this now includes parents, includes adults without kids at home, and it's essential for having access to care. Otherwise, those folks simply did not have the means to find coverage in other ways, and we're relying on basically getting care in the most inefficient, expensive ways in the emergency room or through other means, if they did at all.
And you know, I don't want to keep, I want everyone to understand the reason that I'm not focusing on PBM reform is not because I don't agree with it. I'm totally in favor of the bipartisan issue that we obviously put together on a bipartisan basis. But if you don't have health insurance, you don't have health care, you're not going to have prescription drugs, and you know, you're going to talk about PBM reform, and they're going to say, Congressman, what are you talking about? I don't even have health insurance. So last question, how will Medicaid cuts affect the bottom line of small businesses, whether their employees are without health care and looking to them?
Well, first of all, there's a lot of small businesses who have Medicaid coverage. A lot of small businesses, you know, they may do the next big thing, but until then, they actually have very limited income, and so Medicaid actually provides a baseline, a foundation for our entrepreneurial folks. If you're a diabetic, you can't take the leap to try to do something without coverage to get that life-saving care. And again, a lot of small businesses have their workers tend to be uninsured, tend to be lower income, and it's desperately needed. Those workers can't come to work if they're sick, can't be productive members of their workforce if they're uninsured.
Thank you, Chairman Carter.
The gentleman yields. The chair now recognizes the vice chair of the subcommittee, Representative Dunn, for 5 minutes of questioning.
Thank you again, Mr. Chair, and thank you to our witnesses for being here today. I want to focus on the Medicare Part D linking. To do this, I'm going to highlight a common medication, Gleevec. Gleevec is a drug that's used to treat a number of different cancers, including forms of leukemia in children and adults. The generic for Gleevec became available in 2016, and according to data publicly available through data.cms.gov in 2022, CMS spent over $90 million on the branded version of Gleevec in the Part D program. That's 6 years after the generic was available. In 2022, CMS purchased over 455,000 doses of branded Gleevec and spent $249.58 per dose. However, a 1 month supply, 30 pills of the generic, can be purchased online for $34.50. That's $1.15 per dose, compared to $250 per dose that CMS was paying. This means CMS could have saved $113 million in 1 year alone on Gleevec. Add that together with the pirfenidone that Chairman Carter mentioned, you've got an $800 million plus savings on two drugs in 1 year. I understand that over the last several years, PBMs have moved away from compensation based on rebate retention to compensation based on administrative fees. This merely renames the same sin. It's not different. Despite this shift, the fees that PBMs charge are often still tied to medicine list prices and are certainly motivated by fee income. Breaking the link between PBM compensation and the price of medicines will help fix misaligned PBM incentives that drive up the cost for patients, employers, and CMS. But we must also make sure these sins don't simply migrate into other areas of the supply chain. Fixing PBM's misaligned incentives to prefer higher-priced medicines could increase the coverage. Fixing this could increase the coverage of lower-cost alternatives, including generics and biosimilars, and generate savings for employers, plan sponsors, and CMS. I also want to mention concerns that I have that PBMs are using this system to steer patients to their affiliated specialty pharmacies. The first FTC interim staff report also looked at Gleevec as a case study on PBM abuses. And the report found that in 2022, for the PBM-affiliated pharmacies, commercial reimbursement rates for the generic Gleevec were 40 times higher than the national drug acquisition cost average. And Medicare Part D reimbursement rates were 36 times higher. When the same drug was purchased from an unaffiliated pharmacy, commercial payments were 80 to 90% less, and Part D payments were 30% less. There is massive, massive savings in this for CMS, patients, the government, everybody. This is gravely concerning. Misaligned incentives are contributing heavily to the vertical integration that this committee and other committees in Congress have highlighted. Mr. Chauncey, do you believe that delinking PBM fees from list price is necessary to prevent PBMs from favoring medicines with higher prices? And do you believe that this can help curb consolidation in the PBM industry? Mr. Chauncey. Yeah, microphone.
Would you please repeat your question?
Yeah, so I just do you believe that delinking PBM fees from list prices is necessary and in fact effective?
I don't know all the details about delinking. I do know that it will.
Well, they're competing with you, Mr. Chauncey, and you really need to
Excuse me?
know your enemy.
I do understand that. I do know that that the PBMs are getting a discount off of that.
They sure as heck are. Let me add a second question, Mr. Chauncey. Research suggests that generic medicines in Part D were placed on non-preferred generic drug tiers almost 60% of the time in 2022. What role do you believe rebates played in this trend, and how can delinking compensation from list price ensure seniors have access to cheaper, clinically effective generic biosimilars?
Anytime that we see something that we don't understand, we know that there's rebates on the backside of that.
Yeah, you're right. Mr. Greminger, how do you believe our PBM delinking policy in Medicare Part D will help employers in the commercial market?
So, as you know, Mr. Dunn, the delinking policy does not directly apply to the commercial market. I think that was done intentionally to sort of maintain the ability for some flexibility in the commercial market. I do think that often we will see Medicare policy will flow down to ERISA plans in commercial markets. So, what I'm hopeful is that we'll see a trend against linking fees to the price of drugs in the commercial market, and certainly it's something that, particularly with better transparency that's built into your bill, we would be able to demand and try to change the way that we are paying our PBMs now.
Well, thank you very much. I think this is an exciting area to explore. There's a lot of savings to be had here, Mr. Chairman. Don't give up. Thank you. I yield back.
Gentleman yields. The chair now recognizes the gentleman from California, Dr. Ruiz, for 5 minutes of questioning on this hearing on how the rein-in PBMs will drive competition and lower costs for patients.
Thank you, Mr. Chairman. As an emergency physician, I came to Congress to improve the affordability and accessibility of health care for my patients and the communities that I serve. A large part of that includes lowering the cost of prescription drugs. In the ER, I would treat patients and sometimes send them home with prescriptions. However, if a patient can't afford their medication, they're not going to follow through and buy them. I oftentimes got called by the pharmacist saying that this patient could not afford this medication, and if I could prescribe them perhaps less expensive or maybe even less effective medication. Not taking the medicine they are prescribed can lead to worse health outcomes and increase their chances of ending right back in the emergency room. Increasing transparency for pharmacy benefit managers is a good idea. It's a bipartisan approach that has the potential to address rising prescription drug costs. Mr. Greminger, how does a lack of transparency raise drug prices for patients?
It enables PBMs to play mini games. Often we find that they're sort of one step ahead of us. So every time, as you've heard, 5 years ago, 8 years ago, rebates and discounts were sort of the biggest way that they made money. Increasingly, they've moved away from rebates and discounts, and they've added on fees that are difficult to understand. One of the things that your bill would do is at least try to be more transparent about what those fees are and what sort of value add there is. Give the employers an opportunity to decide, is this something that I'm ready to pay for, or is it something that I don't really need?
Okay. Most prescription drug plans have a formulary where the plan lists its covered drugs in a range of tiers, from low-cost generics to more expensive specialty drugs. PBMs can design these formularies and determine which medications patients can have and at what cost. So, Mr. Greminger, how would increasing transparency help consumers better understand what is on the formulary and result in savings?
It's a terrific question. So, as you suggested, most PBMs have a formulary, sometimes a relatively complicated formulary. We'll also see PBMs change the status of a drug on a formulary multiple times per year, sometimes even multiple times per week, depending on what the size of the rebate is. Right? So if they get a rebate differential, they'll move something from Tier 3 down to Tier 1 and back again. Your bill, the bill in front of us, would require PBMs to disclose what's on their formulary, at what tier, and then actually provide a justification for why it's sitting there, giving employers better information to decide, is this appropriate or is it not? Some of the larger employers out there have instituted what are called waste-free formularies, where they've really sought to try to deal with this now.
Thank you. You know, transparency is always a good idea. It allows sunshine on the working of programs and of government. It prevents corruption. That's why this committee needs to acknowledge the more pressing matter at hand that my Republican colleagues would rather skirt around. The fact of the matter is, while this hearing is about transparency for PBMs as a way to lower costs for patients, Republicans are not transparent in their plot to strip many Americans, their own constituents included, of their Medicaid health coverage to pay for billions in tax giveaways to billionaires. Medicaid provides health coverage for 80 million Americans. That's 32%. And because my constituents are hardworking, under-resourced families, about 42.1% of my constituents rely on Medicaid for their health coverage. Important health services for beneficiaries are at stake, and I have heard from some community health centers and hospitals in my district that have expressed concerns about what would happen to their ability to serve patients should these proposed Medicaid cuts go into effect. Community health centers provide essential health services in underserved community. You know, this is not a blue or red issue. Medicaid cuts would not just hurt residents in blue states, they will hurt people in Republican districts too. This is about people. It's about Americans. It's an American issue. I urge my colleagues to be more transparent themselves, and let's work together in a bipartisan manner to protect Medicaid. None of the other measures we take to lower prices and increase affordability of care matter if our constituents are losing access to care. With Medicaid, the cost of medicines is less. Without it, people will pay much more out of pocket or go without their medicine. Indeed, it will make America sicker and America poorer again. Thank you, and I yield back.
Gentleman yields. The chair now recognizes, the gentleman from Virginia, Representative Griffith, for 5 minutes of questioning.
Mr. Chairman, I heard earlier this morning Ranking Member Pallone say that based on the budget bill, Energy and Commerce was going to cut $1 trillion out of Medicaid. While the budget bill does set a goal of $880 billion for the Energy and Commerce Committee to find in savings, it does not say that it has to come out of Medicaid. And to paraphrase former Chairman John Dingell of this very committee, our committee's jurisdiction includes everything on planet Earth that you can see in a photo taken from outer space. We have thousands and thousands of options in which to look for savings in the federal budget. And in fairness, all these statements about $1 trillion, and I've seen it online this morning being replicated, it's a talking point on the Democrat side to scare the American people, and it is nothing more than disinformation. Now to the matter at hand. Mr. Greminger, I agree with you on CBO being wrong. I agree with you that we need more transparency. I agree with you that we need to move away from the rebate model. But hold that thought. I'll be back in a minute. Mr. Wright, I got this simple little bill called the Fairness for Patient Medications Act, which in the last Congress was H.R. 3285. Now what it says is that if a patient goes to pay for a medication, they won't pay more in their copay than the insurance company or the PBM has negotiated for that price with all the rebates. They won't pay any more than what the insurance company is paying for that medication so that it doesn't become a profit center for the insurance company or the PBM. It looks like to me that's good policy. Are you aware of the issue?
I am aware of the issue. Happy
And
to
can
take a
you
look at the bill.
explain any rational reason why a a consumer, oftentimes not making a whole lot of money, or even, as you said in your opening statement, maybe uninsured, is going to pay more for the medicine than their insurance company. I guess not uninsured, but why an insured who's paying for their insurance or their employer's paying for the insurance would pay more for the medicine than the insurance company or the PBM's paying. Can you explain that to me?
You shouldn't ask me, you should ask the insurers. I would say
teeing it
that I
up.
think the argument that I have heard is that to the extent that the insurer, in some cases the PBM, is negotiating a formulary, a broader range of drugs are included, and then the question of where do various drugs appear on certain formularies as part of the negotiating power of the insurer and PBM. We think negotiating power is a good thing, but if it ends up actually increasing out-of-pocket and co-pays for patients, that's not good, and so we'd be happy to look at the bill.
I appreciate that. You know, in 2018, we had bills in Congress. We also had bills that passed earlier than the congressional bill in the Virginia legislature. Senator Todd Pillion, who I happen to represent, introduced the bill to say that pharmacists could tell you if you showed up, and I had a constituent who had this problem prior to 2018. They showed up one time in their insurance, there was some kind of a glitch, and the pharmacist said, well, you can pay me this amount over the counter. And she goes, well, that's less than what my copay is. And he goes, yes, ma'am, I can't tell you that, but since your insurance is currently lapsed for a day or two, I can inform you that you can pay this. So she never used her insurance again for that medication. She just paid cash to the pharmacist. That doesn't make any sense to me. And Todd Pillion put a bill in and said the pharmacist could actually talk. There used to be a gag order, and the pharmacist could talk about it. Now, Mr. Greminger, when Todd passed that bill, Senator Todd Pillion in Virginia passed that bill, WRIC ABC News of Richmond labeled their article on it as lawmakers take aim at scam, driving up drug prices. Last year, your organization opposed my bill. We agree on a lot of things. I'm trying to figure out why your organization would be in favor of a scam driving up drug prices. Please tell the American people.
Mr. Griffin, to be honest, I do not recall that we opposed your bill. I would be delighted to come back and talk to you more about it because I think on face, it makes a lot of sense.
All right, I appreciate that because last year you all opposed it, and I just, for the life of me, can't figure out why a patient should pay more, an insured patient pay more than what their insurance company's paying for it, what they've negotiated to pay for. And part of it comes back to the rebate issue, which I agree with you, probably need to move away from. Mr. Chairman, I appreciate this hearing, and I appreciate you, and I yield my time back.
The gentleman
All
yields.
14 seconds.
The chair now recognizes the gentlelady from Michigan, Representative Dingell, for 5 minutes of questioning on PBM reform.
Thank you, Mr. Chairman. And as you know, this is one of my deep passions, and I feel strongly about it, as you do. Although I would just say to my colleague, if Mr. Dingell were here, he would still, he taught me a lot. And the first question I'm going to ask is, when you look at the world and you look at everything that you're talking about, where is the $800 billion going to come from? And the only thing we talk about is Medicaid. And when we want Medicaid, we here are worried about what those kinds of cuts are going to do to Medicaid. So we're really glad if you're not going to cut Medicaid and you're not going to hurt people, but what are you going to cut? And I know you're not going to answer that question, but I thought I'd ask that question. And I'll even build on what he said and say negotiating power for PBMs gives the PBMs their cut and screws the patient every single time. And that is one of the problems. And there still is a gag order. And the only way a lot of us learn about this is we go talk to pharmacists that aren't taking care of us, but somebody says, will give us the answers. And they'll tell you, I can go and buy my pills a whole lot cheaper, just even at cost, than covering them by my copay. And there's something wrong with that system. So as you can tell, I think they've been allowed to operate unchecked for too long. I want to work with my colleagues to solve this issue. We had an opportunity to provide critical checks on PBMs last year in the continuing resolution, and as my colleague, the ranking member said, bipartisan solutions were included in the text, such as bans on spread pricing, clarity on enforcing Part D contract terms, and establishing surveys to be able to hold PBMs accountable to deliver fair prices. But at the last minute, Elon Musk and the Republican Party opted to back out on the deal. I hope that the hearings today are a sign that we're really going to do it, and we're not going to let anybody threaten us, but we're really going to get it done this time, Mr. Chair. You know I want to work with you on this. Back home, I'm hearing from far too many Michiganders, especially seniors, who can't conveniently access their prescriptions they need due to the exploitative PBM practices complicating access to the local pharmacies they depend on. They're an invaluable resource in underserved communities and not even in underserved communities. I get a lot more answers from my local pharmacist, and I get educated a lot, and we've got to ensure that they remain open and competitive. So I have no PBMs Act legislation, and this bill would implement common sense reforms to the PBM industry that will put a stop to some of the tactics that distort prices, harm pharmacies, and drive profits at the expense of patients. It will strengthen PBM accountability and ensure Americans can get the medications that they need closer to home and at pharmacies they trust. Mr. Chancey, through your experience as a pharmacist, how would ensuring that PBMs must align with Medicare plans for prescription drugs allow better access for seniors who are trying to fill their prescriptions?
So your question was, would you say that last line again?
How would ensuring that PBMs have to align themselves with Medicare plans for prescription drugs, how would it help seniors have better access who are trying to fill their prescriptions?
Well, I think a good mentor of mine shared with me where there's mystery, there's margin, and there's way too much mystery with the PBMs. And I think that transparency is going to help to clear up a lot of those issues. There's too many games and there's too many hoops. Some of the life-saving medications, they have to go through all kind of prior approvals and a lot of things, and it's just really to prolong a patient not getting the medication. And unfortunately, the patients pay for that. I think that, that the relevant and reasonable contract terms between the PBMs and the pharmacies will clear up a lot of the issues that we're dealing with today.
Thank you. Mr. Fiedler, PBMs have restricted access to a patient's choice of pharmacy and medicines that are right for them. Back in my district, I hear from far too many Michiganders, especially seniors, who face complications accessing the local pharmacies they depend on because of exploitive PBM practices. I'm going to show you an example. Last night, I forgot my inhaler because I only have one, because my local pharmacy can't fill it because I can only get the new medicine the doctor prescribed at one of the big ones. So, Mr. Fiedler, you mentioned in your testimony that a small number of firms control a large share of the PBM market, which allows them to demand higher prices to earn excessive profits, and I suspect control the supply. What reforms could be made to reform the competitiveness of the PBM market?
So it's a challenging problem. I think one promising strategy is greater transparency. I think the bigger problem is that's probably a somewhat limited solution. And so if you really want this market to be more competitive, you need more PBMs, and the question is, how do you get there? Breaking up existing PBMs is probably a challenging undertaking, but I do think there's some room for antitrust regulators to be looking at, new entrant PBMs and making sure that those PBMs aren't being acquired by incumbent PBMs in hopes of building a more competitive market over time.
I'm out of time, but I didn't think the creation of more PBMs would be an answer to anything. And with that, I'll yield back.
The gentlelady yields. The chair now recognizes the gentleman from Florida whose team last night was beat by the Georgia Bulldogs. Representative Bilirakis for 5 minutes of questioning. Staff wrote that on there. I just reading what staff wrote.
You can move to take his words down if you want.
Let's compare records, Mr. Chair. All right. Okay, this is important stuff, too. All right, Mr. Chancey, the Florida legislature recently passed legislation requiring any willing pharmacy language in addition to PBM transparency requirements. This language requires a PBM to include any pharmacy in their network as long as certain conditions are met, giving seniors more care options and affordable options. Again, more care choices and affordable options, excuse me. One of the policies originally included in the December CR, and of course it was removed at the end, was language to enforce any willing pharmacy in Medicare Part D. Can you share how this language will help your patients and seniors in Medicare?
Yes, sir, I think that's a great question. I had a patient just a few weeks ago that she came in on a Friday afternoon around 3:30, 4 o'clock, had her children with her, and she was heading out of town. She said, can I go ahead and get the prescription filled? She dropped it off at the drive-thru, and she said, I need to go to the bank and come back. Within 10 minutes after we filled the medication, she had not come back yet. We got a call from the PBM, and they told us that we needed to reverse that claim, back it out, and transfer that claim to Walgreens in the next city. And our pharmacist said, well, she came to us. She chose us to fill this, and you've approved it. And they said, well, if you don't do this, you're going to be in violation of your contract. So my pharmacist backed it out and transferred the prescription to Walgreens. And so the onus of having to explain something that we didn't understand was put on us when she came back. She was in a hurry to get out of town. But that's the type things that are terrible for the patients, they're terrible for us, and it takes away from the care and convenience of the patient. And it also limits access.
Thank you. Mr. Grimminger, can you further detail about why building off Florida's PBM accountability law with the PBM transparency policy we've marked up is important for employers at the federal level?
Certainly. So a couple of thoughts. We have a fundamentally broken market when it comes to the PBMs and the interaction with the drug companies. At some level, the two sides who like to hate each other are really playing very much the same game. Drug companies are winning, PBMs are winning. Drug companies have justifications to have higher list prices. PBMs have justifications to have larger rebates and larger fees that are tied to the price of the drugs. The transparency that is provided under your bill would finally allow employers to actually understand how much money the PBMs are making on each drug, how much money the employers are paying on each drug, how much money the chain or retail or mail-order pharmacies are making on the drug, whether or not those fees are actually higher for chain or retail or mail-order pharmacies owned by the PBMs as opposed to going to one of Mr. Chancey's units. It would provide the kind of information that employers could actually use to price shop, identify lower cost options, better drugs, and ultimately reduce some of the gaming that we see in the commercial market. But one of the things that's appealing about your bill is that it does not tell employers specifically how they have to structure their market, right? It says that the PBMs have to pass on all rebates. It still allows for spread pricing. It still allows for value-based purchasing. It still allows for a lot of different design that PBMs and employers could actually use in sort of a fair and free and transparent market to actually look for better options for drugs.
Thank you. Mr. Chancey, I still have some time here. Mr. Chancey, I've been a longtime supporter of policies to improve the quality of life for diabetic patients, and I co-chair, as Ms. DeGette said, the diabetic conference. I've become aware of a pharmaceutical manufacturer launching two different versions of an insulin biosimilar, one branded and one unbranded, at two different price points in order to land on a PBM formulary. In many cases, the higher priced branded reference product was exclusively covered by plan sponsors, completely limiting access to a cheaper, therapeutically equivalent biosimilar, or requiring patients to go through unnecessary step therapy in order to access a cheaper biosimilar version of the drug. Can you explain what this means for seniors who rely on insulin in terms of what they're paying at the pharmacy counter? What can we do to address this particular issue? Again, for Mr. Chancey.
Another good question. I think that when it doesn't make any sense when there's a cheaper generic version and the preferred drug on the formulary is a brand name drug and they're having to pay a higher brand copay for that drug. So, we know that that's rebate driven. So that's unfair to the patient, and it takes the cheaper version away from them.
Very good, thank you. Mr. Chairman, you know, in your particular bill, you have this particular language that's going to be very helpful to the consumer.
Yeah.
And it came from the University of Florida School of Pharmacy. I'm assuming that it did. So it's Florida law.
The gentleman yields.
All right, very good, thank you.
Yeah, I got you. All right. The chair now recognizes the gentlelady from Illinois, Representative Kelly, for 5 minutes of questioning on PBM reform.
Thank you, Chair Carter and Ranking Member DeGette, for holding today's hearing, and thanks to all the witnesses for your participation. I want to start by pointing out, which you've heard already, but it's very important, that last Congress, this committee already worked on solutions for the American people regarding PBM reform, including commercial market, PBM transparency, Part D delinking, and transparency and a ban on spread pricing in Medicaid. And yet, in December 2024, after a tweet by Elon Musk, the deal worked out by the four corners of the chambers was taken down. So here we are again, all because some of my colleagues don't want to stand up for the well-being of all Americans. Nevertheless, I look forward to working with this committee ahead of the March deadline to see those already negotiated reforms to the finish line. When we passed the American Rescue Plan, a provision of my legislation, the Care for Moms Act, was included to extend Medicaid postpartum coverage from 60 days to 1 full year. This extension has been a crucial lifeline for mothers and their infants, and I'm proud to say that this is no longer a temporary measure. The expansion of Medicaid postpartum coverage is a critical part of our efforts to address the maternal health crisis in this country, as the Medicaid program covers about 4 in 10 births in the United States. Dr. Fiedler, what role does Medicaid play in ensuring pregnant women and children have access to health care?
So Medicaid covers about 4 in 10 births in this country, which is larger than any other single payer. And so it plays a critical role in ensuring they can both access the health care they need, but also ensuring financial security, right? One of the core roles of health insurance is making sure that when you do have big health expenses, that's not a big hit that keeps your family from meeting other needs, which we know, families expecting kids have a lot of other needs on their budgets.
Thank you. Currently, 49 states and Washington, D.C. have already made this extension permanent. Even Republican-leaning states like Alabama, Tennessee, Kansas, Oklahoma, and Nebraska have enacted postpartum Medicaid extension legislation. With cuts to Medicaid funding, states will have to come up with significantly new resources of funding or more likely find ways to cut Medicaid. This means cuts to coverage, cuts to benefits, and cuts in payments to hospitals and community health centers. Dr. Fiedler, with even lower Medicaid payments and more uninsured people, do you expect that more maternity care units will close, particularly in rural and underserved communities? And what impact will that have on maternal and child health?
So one of the things we have exceptionally good evidence on is that when Medicaid coverage is broader, the uncompensated care burdens borne by healthcare providers and particularly hospitals fall. Now, there are probably some health systems that can, absorb more uncompensated care, but there are some that can't. And, ultimately, probably some that are, forced to close or cut back service lines. So, my expectation would be that if we were to see big drops in Medicaid coverage, we would see, some closures of services that people depend on.
Thank you for your response. Discussing PBMs means nothing for people who lose their health insurance coverage because Republicans and the Trump administration want to slash Medicaid. In the state of Illinois that I'm proud to represent, there are 2.4 million residents covered under Medicaid, and that includes 35.4% of all children, 40% of moms giving birth, and their newborn babies, 40% of working age adults with disabilities, and 69% of people living in nursing homes. Mr. Wright, what impact has Medicaid expansion had on the continuity of coverage and health outcomes, particularly for low-income parents? Thank you.
Your line of questioning on maternity care is absolutely right. There's no more important program for keeping both babies and mothers alive and well than Medicaid. It's 40, in some states, 50% of the population. And to continuity of care, it's a safety net for all of us. If we find that we're in a situation where we lose a job or get divorced, It's the ability for people to continue to get the care that they need, even if they are in the middle of postpartum treatment, even if they have a chronic condition like diabetes or something that needs ongoing care. It's the ability for people to continue to have the coverage and have a usual source of care and not just end up in an emergency room in the most expensive, least efficient place to get care. So it's incredibly important for continuity of care for all folks, but especially for children and parents.
Thank you so much. And there's thousands of people that won't have care because they've just been laid off or fired. I yield the rest of my time to Ranking Member Diana DeGette.
Thank you so much. Mr. Chairman, I'd ask unanimous consent to put an article into the record from today's New York Times, which is entitled, "What Can House Republicans Cut Instead of Medicaid? Not Much." It refers to the $880 billion E&C has been asked to find, and it points out that if you cut everything else in the Energy and Commerce Committee besides Medicaid, you'd still be $600 billion short. But if you used creative budgeting, not to worry, you could save maybe $187 billion. So the only thing we can cut is Medicaid. I'd ask unanimous consent to put it in the record. No, we're going to give it to you right now.
So we'll study that.
Thank
We
you.
won't accept that in just yet. Ms. Kelly yields back and recognize the gentleman from Pennsylvania, Dr. Joyce.
Thank you, Mr. Chairman and Ranking Member DeGette, for holding this important hearing and to our panel for testifying. This is a great opportunity to examine the bipartisan cost-saving reforms that passed through this committee and the House of Representatives in the last Congress. While these reforms ultimately were not signed into law, we were successful in building the necessary momentum for these positive changes to occur. We can see the impact of our efforts through actions that some pharmacy benefit managers have taken to institute additional reporting to their patients and to their plan sponsors. Now, in the 119th Congress, we have an obligation to return to our work of lowering prescription drug costs and improving access to affordable medications for our constituents, particularly for Medicare and Medicaid beneficiaries. PBMs were created to negotiate drug prices down on behalf of plan sponsors. Despite this, we have continued to see an increase in what plans and patients are paying for prescription medications. We need to create an environment that increases competition, one of the most consistent drivers of lower costs. Because of the complex nature and opaque component of these operations, it's difficult for plan sponsors to effectively engage in truly competitive processes for choosing their pharmacy benefit manager. Mr. Greminger, can you speak on how the transparency requirements that passed through this committee last Congress can help drive competition through an increased ability for employers to compare options and negotiate effectively?
Certainly. So, as you identify, Congressman, the bill under your consideration provides really end-to-end transparency in a way that we've never seen before in the PBM market. It allows plan sponsors to understand what the initial price of the drug was from the original sale by the group purchasing organization, all of the discounts and fees that might have been assessed on that drug, and then finally get to sort of what the net cost was to the plan sponsor. Right now, almost none of that information is available to us. As I mentioned in my opening statement, plan sponsors are fiduciaries over their plan assets. We actually can be sued. In fact, 2 large organizations have so far been sued, allegedly because they weren't overseeing their PBM contracts effectively. We were paying too much for drugs. Right now, we don't have the ability, in many cases, to really understand what we're paying for any particular drug, whether we're overpaying because there's a weird formulary placement where you're having a higher price drug at the bottom of a formulary, lower price drug at the higher end of a formulary, et cetera. This bill would correct all of that and provide us with the transparency we need. We would still be fiduciarily liable, but there's no way you're going to see a prudent fiduciary choose to say, yeah, I'm going to have a $5,000 drug at the base of a formulary and go through prior authorization to get to a $500 drug. That won't happen because plan sponsors will have the transparency need and, frankly, the fiduciary requirement that they are placing the drugs appropriately and negotiating for the best prices.
The United States is home to world-leading medical innovation. In fact, many on this committee have heard me say that innovation is truly the cornerstone of American medicine. There is a need to find creative solutions for coverage and payment of these innovative medications to make them accessible at an affordable price. Mr. Greminger, how does value-based purchasing play a role in getting these advanced medications into the hands of the patients who desperately need them?
Yeah, so value-based purchasing can mean a lot of things, of course, but one of the things that's exciting about it is it's the notion that instead of paying for a drug based on sort of whatever the list price is, whatever rebates you might have been able to negotiate, it's based on sort of unique clinical value above what else is available in the market right now. I think that's definitely the direction we need to head, and we're starting to see more innovation to be able to see there are absolutely some very high-priced drugs that are also transformative. They're life-saving. They have the ability to prolong people's lives and give them back their lives. There are a lot of low-value drugs out there that are equally expensive and don't have that same kind of change. Under a value-based purchasing arrangement, the employer, purchaser, plan sponsor is paying based on unique value above replacement effectively, which is, I think, the direction that we need to go. It would allow for pharmaceutical companies to make quite a bit of money on drugs that are truly innovative and not make much money on drugs that aren't innovative at all.
Again, Mr. Chairman, thank you for holding this hearing today, and I thank the witnesses for taking time out of their schedules to be with us, and I yield.
Thank you. The gentleman from Pennsylvania yields, and the gentlelady, Dr. Schreier from Washington, is recognized for 5 minutes for her questions.
Thank you, Mr. Chairman, and thank you, Ranking Member DeGette. Thank you to all of our witnesses today for speaking about this important topic, the role of pharmacy benefit managers, or PBMs, in raising drug prices for patients, putting local pharmacies out of business, and covering up the financial shenanigans and profit-taking behind all of it. I think, or I know, we all agree that increased transparency and reform regarding pharmacy benefit managers is needed. In fact, I know this because this committee worked in a bipartisan fashion last Congress to prioritize this issue and pass a number of PBM reforms that were ultimately included in a great end-of-year bipartisan bicameral package. In fact, the savings from these bipartisan reforms were set to pay for bipartisan priorities like extending telehealth flexibilities and community health center funding. Unfortunately, my Republican colleagues let unelected billionaire Elon Musk kill this bill via X. The committee is now again considering PBM reform, but at the same time, they're about to make drastic and unconscionable cuts to Medicaid in order to pay for tax cuts that benefit the very man who tanked this deal in the first place. Let's be clear. Republicans voted just last night to take an axe to Medicaid. We have heard evidence of this from many of my colleagues. And Medicaid is a program that pays for health care for nearly half the pregnancies and children in this country, for people with disabilities, for rural hospitals and nursing homes, and they're cutting this to pay for tax cuts for billionaires and corporations. I want to pivot for a moment to something important in my district, rural hospitals. Medicaid is a critical source of insurance coverage for rural America, with nearly a quarter of people under 65 on Medicaid and 22% of people dually enrolled in Medicaid and Medicare. My district is about 10,000 square miles. It is mostly in central Washington. And without rural hospitals, my constituents would have to travel hours, either to Seattle or Spokane, for regular care. They serve a patient population that is sicker and older and less likely to have private insurance coverage, and they operate on the slimmest of margins and are a critical access point for the healthcare system. They, in fact, will be the first to tell you that Medicaid is the leanest payer out there. They can barely make it through. So the fraud and the abuse and the bloat that my Republican colleagues are trying to go after just does not exist in this program. I will warn this committee that should these Medicaid cuts go into effect, the first thing to go, especially in our rural communities, will be obstetrics and delivery. And we have already had one hospital system almost have to lose OBGYN and to not be able to care for pregnant women and deliver babies. And so this poses an additional risk to women and babies. Dr. Fiedler, you just talked about the impacts of Medicaid cuts to women and children in particular. Can you expand on the impact that almost $1 trillion in cuts to Medicaid would have on rural hospitals and their ability to deliver care?
So as I alluded to earlier, we have very good evidence that Medicaid expansion and Medicaid coverage generally reduces the burden of uncompensated care on hospitals. And which types of hospitals is that going to create the biggest challenges for? It's the ones that are financially precarious to begin with. And so, in many cases, it's not always the case, but in many cases, rural hospitals are in financially precarious situations. And so that would be one of the places that you would look to see, where are major disruptions likely to occur.
And it is dangerous and expensive to deliver babies in an emergency room. Just touching in my last 25 seconds on PBMs, we know that the incentives are perverse in terms of profit making, and I was wondering, Mr. Greminger, if you could just comment about the importance of transparency in these negotiations between PBMs and drug manufacturers, in how that could help us understand and then lower drug prices for American consumers.
So today, as I said in the opening statement, employers really don't know what they're paying for each individual drug, which is obviously hugely challenging. I would add very quickly, we don't really know the nature of the negotiations between the drug makers and the PBMs themselves, right? All we can sort of suss out is what appears to be in those contracts. And what we see is a situation in which both the drug makers and the PBMs seem to be winning, and working families and American employers seem to be losing.
That's right. Thank you, and I yield back.
The gentlelady from Washington yields back, and I recognize the gentleman from Ohio, Representative Baldwin, for 5 minutes to ask his questions.
Thank you, Chairman Dunn, and thank you all for being here today. During the 118th Congress, there was thoughtful legislation put forward by my colleagues, which we've talked a lot about this morning, pushing for increased transparency and accountability for pharmacy benefit managers. Today, I am hoping we can further illustrate why this sort of legislation is so desperately needed. PBMs were designed to help manage prescription drug benefits, negotiate better prices with manufacturers, and help control costs for insurers and patients. However, as time has gone on, their role has morphed into something that has seemingly lost sight of these goals. In 2018, the Ohio Department of Medicaid conducted an audit, finding PBMs were making significant profits through spread pricing. This audit, which covered 2017 to 2018, showed that PBMs overcharged the state of Ohio $224 million. Ohio is not alone in this abuse. Following the findings of the audit, my state became the first to act, and as of now, 16 states have banned spread pricing. I look forward to hearing from all of the witnesses today, and I appreciate your time in discussing this very important matter. My first question is for the pharmacist, Mr. Chansey. As a result of PBM's indecent practices, independent pharmacies around the country are closing. I know that in my district, we are not strangers to this issue. I hear from my friends, family, and constituents alike that their trusted pharmacies have closed after decades of serving their communities. Pharmacy deserts have continued to grow, and patients no longer have access to patient-pharmacist relationships that has helped them manage complex medication regimes and diseases. It is estimated that between 2018 and 2021 alone, the number of pharmacies has declined in 41 states. So this is not just an Ohio problem. This is not a rural problem. This is a countrywide issue that needs addressed. And transparency is unlikely to be the sole solution. As I discussed earlier, the Medicaid spread pricing ban prevents PBMs from engaging in spread pricing and requires them to pass along the full reimbursement amount to pharmacies, addressing transparency and reducing the financial burden on the Medicaid system. Mr. Chansey, can you talk to me about how the spread ban can help address the pharmacy's issues that you have experienced?
Yeah, certainly. I would like to start off by saying that 20%, this legislation really addresses over half of the independent community pharmacy businesses. 20% of the business on average is Medicaid and 35% is Part D. I think that this transparency and stopping the spread pricing is going to lower the cost of the drugs, and it's going to level the playing field Right now, it's not very level. And just since June of '23, we've lost 450 of my colleagues. And at that rate, we just can't continue. It seems like a crisis to me. We've got to enact this legislation, and I would like to say yesterday. But even if we voted it in today, it's going to take 2 to 3 years before that's going to really have the impact that it needs. So I think it needs to be done sooner than later.
Thank you. My next question is for Mr. Grimminger. Thank you for being here. What a PBM does with rebates is a critical part of transparency. Of course, we want to see competitive market. But the other part of this is that I really want to drive home is that we want to see 100% of rebates passed on to clients. This is a critical part of this equation. Quite frankly, how is it right now? We aren't seeing these large PBMs aim to lower the cost of goods for their own profit margins and lower the cost of goods sold for their clients by passing these savings on. How can Congress ensure competition while also ensuring that the clients, the employers, and patients feel the effects of savings?
Thank you for the question, Congressman. I think one of the things that's really appealing about this legislation is that it includes all rebates and discounts from the very beginning of the chain all the way to the very end. I spoke about this just a little bit in my written and oral testimony, the role of group purchasing organizations, or sometimes called rebate aggregators. These are theoretically separate companies, separate corporate entities, often based overseas, that are wholly owned by the PBM. Their entire reason for being is to aggregate rebates and be the initial purchaser of drugs. Before that is then passed on to the PBM, which is the next level in the chain of the corporate entity. We hear from employers all the time that they are told by their PBMs, I'm passing on 100% of our rebates to you. We then ask, so which rebates are we talking about? Like, oh, well, once the GPO sells it to us, then everything else flows on to you. Of course, omitting the fact that they are taking a huge rebate cut between the GPO and the PBM themselves. I want to say very clearly, it's the same company. It's the same company with just 2 different corporate structures. I think it's critical that we actually are able to watch the flow of rebates from the moment the initial batch of drugs is purchased by the PBM or the GPO from the employer, or excuse me, from the manufacturer, all the way to the very end where we actually receive the final discount.
Thank you very much. Mr. Chairman, I yield back.
Thank you, Mr. Balderson. Yields back, and we now call Ms. Fletcher from Texas. Give her 5 minutes for her questions.
Well, thank you so much, Mr. Chairman, and thank you to Chairman Carter and Ranking Member DeGette, and thank you to all of our witnesses today for your testimony. I was struck at the beginning of this hearing when Chairman Carter said that the true reason that we're having this hearing today is because of a sad and difficult story about one patient and their experience with delayed access to the drugs and the care that they needed. And that is the true reason that we're here doing this work, but that's not the true reason we're having this hearing today. And I want to associate myself with the comments that Ranking Member DeGette made. The true reason that we are here is because in December of last year, Elon Musk decided that he thought our bill, our continuing resolution, was too big. It had 1,500 pages or something like that. Too big, can't possibly all be good. Don't do it. And just like that, years of hard work, including hard work to deal with this very issue, got cast aside. And so we're having a hearing today on something we've already agreed on, we've already worked on, and we have already addressed. It's important that we do it, so I'm glad that we're continuing the work. But I think that what we know is that we've got an agreement here. Commercial market PBM transparency was in the agreement we had in December. Part D delinking and transparency was in the agreement. A ban on spread pricing in Medicaid was in the agreement. We have already made an agreement on this, and the only reason it isn't law is Elon Musk. I think that is important for everyone here to know. I think that is important for everyone in this country to know. This committee and this Congress has consistently allowed Elon Musk to substitute his own uninformed judgment for all of ours, and it's got to stop. It has got to stop. So instead of rehashing some of these reforms that we've already agreed on, I want to spend the time that I have left talking about and asking about the budget resolution that House Republicans passed last night that directs this committee, the Energy and Commerce Committee, to cut a minimum of $880 billion out of spending. Now, we heard time and again yesterday in our markup that we weren't going to get to cuts to Medicaid because Medicaid wasn't in that budget resolution. We know on this committee that that is where that money, it's the only place it can come from. So, Mr. Wright, in your testimony, you made it very clear that threatening access to coverage, like Medicaid, would increase costs for families far more than any PBM abuses. And I want to ask you to take some time to talk to us about the importance of Medicaid coverage, especially on an issue that's very important for those of us in Texas, as well as people across the country, the importance of Medicaid coverage for pregnant women, which covers Medicaid covers 50% of births in Texas. Can you talk about what the impacts of losing Medicaid coverage in Texas and states across the country will mean?
I mean, obviously, it would have devastating ripples throughout the healthcare system, and not just for the people who do have Medicaid coverage, but for the system as a whole. In many of, whether it's community clinics or rural hospitals, in many cases, Medicaid is the biggest funding source. And so if you're in that community, if those institutions get hit with a big cut, that impacts everybody in the community, whether or not you're in Medicaid specifically. If a maternity ward, which already has we've seen closures already of, if they lose funding, and again, 50% of births are paid for by Medicaid. If they lose that funding, that actually could potentially mean the closure of a maternity ward for everybody in that area, creating further maternity deserts in our country at a time when folks are talking about how can we better support parents, how can we better support the process of people starting a family. And so it is incredibly important, and just not, both the prenatal and postpartum care is so important. Those first few years of life are probably the best investment you can make in terms of a child's health, not just for that time, for into their life. That's when brain development happens, and there's reams of data and research that suggests that those kind of investments are some of the best investments you can make. But if you have a cut of the scale that is being talked about, it's almost impossible to think how those will not be impacted.
Thank you so much. I have gone over my time. I do have some more questions for you, so I'm going to submit them for the record and look forward to hearing your responses. Thank you so much, Mr. Chairman. I yield back.
The gentlelady yields. The chair now recognizes the youngest pharmacist in Congress, Representative Harshbarger from Tennessee, for 5 minutes of questioning.
Thank you, Mr. Chairman. I appreciate that reference to my age. And thank you to the ranking member, and thank you to the witnesses for being here. Yes, I am younger than Buddy. I've been a pharmacist, well, I better not tell you how long, or then you're going to know how old I am. I've been a pharmacist a long time, and every week I hear from independent pharmacists from East Tennessee, across the state, from all over the country about these manipulative practices of PBMs. And all you have to do is read the last two interim reports from the FTC to understand that PBMs can distort competition. They steer prescription drug coverage to whatever pads the bottom line, and essentially they print their own money. And I say this in every PBM hearing, and I'm going to say it again today. PBMs don't treat a single patient, they don't cure a single disease, and they don't insure a single American. So the bottom line, it's all about the patients, isn't it, gentlemen? It certainly is, and how they're losing access to pharmacy choice, who in most communities are your independent pharmacies who are the most trusted and the most readily available healthcare provider in that community. So PBM reform is a bipartisan issue, and you know what that means? That means that both sides agree on this issue. It's not an issue of contention. So it's important that we get some PBM reform done. Mr. Chancey, this is a yes or no question. Is it sustainable for PBMs to often reimburse independent pharmacies below their acquisition costs for drugs? I've had to deal with it in my practice and have to deal with the take it or leave it contracts that they offer. the abusive audit practices they do, whether it's a desk audit or they come into your pharmacy and audit. And then what they do after the fact is they reduce pharmacy reimbursements because of ambiguous, shifting, unpredictable metrics. And I guess my question for you is it sustainable for your pharmacy practice, yes or no, sir?
It is not sustainable.
It's not, exactly. Thank you for agreeing with me. It's almost like you're playing a high-stakes game without knowing the rules. And really, it's a game with no rules, isn't it? That's exactly what it is. But it's not a game, is it? Because who suffers in the end? It's the provider and the patient. So, Mr. Chancellor, this is another yes or no. Would you agree that the fairest and most transparent way to reimburse pharmacies for prescription drugs would to use the national average drug acquisition cost plus a reasonable dispensing fee? Yes or no?
Yes, I do.
Yes, I do too. Mr. Grimminger, thank you for being here today, sir. We know about the vertically integrated organizations and how they have tremendous influence over which medications patients have access to, when and where they get those drugs, where it can be dispensed or administered, and the amount paid out of pocket by patients. I've had to deal with this. In your view, is the vertical integration of these companies hindering market diversity and competition, yes or no?
100%.
100%. And let me tell you about legislation that I proposed. I've introduced a bipartisan legislation called Patients Before Monopolies Act, and that would require health insurers and PBMs to divest from their pharmacy businesses, eliminating conflicts of interest and creating a more transparent system. And I'm sure people love that, but the PBMs don't like it. So this is for Mr. Chancey again. Let's talk about patient steering. PBMs are now requiring patients to use PBM-affiliated pharmacies, including mail-order and specialty pharmacies, to where if you've got a cancer patient, they can't go to their oncologist or their community pharmacist. And now it's filtering over to HIV patients and other chronic disease patients. And I believe patient steering myself. I believe patient steering or mandating the use of a PBM-owned pharmacy should be prohibited across all federal plans. Would you support a prohibition on patient steering by PBMs to their affiliated pharmacies, yes or no?
Yes, I would.
Okay. This is going to be a lightning round. I've got 31 seconds. Mr. Chancey, Mr. Grimminger, many of us in Congress believe that misaligned incentives are at the root of the problem with high prices in America today for drugs, and that PBMs are taking advantage of these misaligned incentives. Would you agree that if patients have to pay a certain percentage of the drug sticker price, reducing drug sticker prices can reduce patient out-of-pocket cost, yes or no?
Yes.
Yes.
Okay. Would you agree that PBMs and brand pharmaceutical manufacturers sometimes enter agreements to exclude lower-cost competitor drugs from the PBM's formulary in exchange for increased rebates from the brand name drug manufacturers?
Yes.
I go as far as to say it's often, not just sometimes.
Yes, exactly. Would you agree that higher price out-of-pocket costs for patients can adversely impact adherence to prescription regimens, yes or no?
Yes.
Yes.
Would you agree that poor patient prescription adherence can lead to poor health outcomes?
Yes.
Yes.
I've only got 3 more, buddy. It's quick. Do you agree that excluding lower-cost generics from formularies and offering only the more costly brand-name drugs reduce access to care?
Yes.
Yes.
Do you agree that brand mandates should be prohibited by Medicare Part D?
Yes.
We don't have a position on Medicare Part D policy.
Well, you should say yes. Would you support requiring the inclusion of generic drugs on formularies? Last question.
Would you repeat that, please?
Would you support requiring the inclusion of generic drugs on formularies?
Yes.
Yes, so long as the net price to the employer is below that of the brand.
Absolutely. Thank you, sir, and I yield back, Betty. Thanks so much.
The gentlelady yields. The chair now recognizes the gentleman from Massachusetts, Representative Auchincloss, for 5 minutes of questioning.
Thank you, Chairman. I want to associate myself with the excellent line of questioning from the gentlewoman from Tennessee, with whom I'm co-leading 2 pieces of follow-on legislation to these bipartisan reforms, the Pharmacist Fight Back Act and the Patients Before Monopolies Act. And indeed, we seem to be in vigorous bipartisan agreement on this issue of PBM reform. So I want to actually pursue an area of disagreement, because that's how I learn better. Dr. Fiedler, in your written testimony, which I tried to review pretty carefully, you really seem to push back on the idea of getting rid of rebates. You really defend rebates and actually kind of emphasize that delinking may not work very well. And I want to engage with you on that question, because maybe I'll learn something here on this. One of the things you do emphasize is competition and the value of competition with new PBMs entering the market. How are these new PBMs, most of whom are flat rate PBMs though, transparent flat rate PBMs, supposed to compete when the plan sponsors are locked in with rebate deals that the incumbent PBMs have? That's especially relevant because of the 2021 Consolidated Appropriations Law that made these plan sponsors fiduciaries. So there's a real opportunity now for competition from these flat rate PBMs, because these plan sponsors are fiduciaries and they know that their employees are getting screwed over, and so they really have a liability here, but they're locked in with the rebates. So doesn't your point about rebates contradict your point about competition?
So I think one of the challenges with the idea that the solution here is more competition in the PBM market, and I think we should try as well as we can, but I think one of the real challenges is that it is probably the case that the big PBMs, when they're going up against the manufacturers, have more leverage. And I think that's just the reality of this market. And so the trade-off is, do we want a more competitive PBM market that I think does mean that the PBM profit margins would come down, and that would be good for clients? But I think there is a potential trade-off in terms of what that does to drug prices. I think my best guess is on net consumers save money from that. But I think there is a trade-off, and I don't think the evidence we have on that question is perfect.
Yeah, I'm not sure I'm ready to accede to consolidation as the only way we can get scale economies. I mean, the genericization function is how we get lower prices, not necessarily just through plan sponsor leverage. The other question about rebates I have is, of course, rebates inflate list prices, right? They pump them up. Now, we can debate plan sponsors and pharma and PBMs, and they're all kind of shuffling money around, but what we know is that patients pay their out-of-pocket out based on the list price, not the net price. So your defense of rebates seems to contradict the idea that we're trying to lower out-of-pocket costs for patients, yes?
So that assumes that if you switch to a different pricing system, that patient's coinsurance rate or deductible are going to remain the same. And I think what's happening in many cases is the insurer, the plan sponsor, is setting that deductible or coinsurance rate to get cost sharing at the level they want it to. So if you brought the price down to the net price, I think what we'd often see is the insurer deciding, okay, we're going to apply a hard coinsurance rate. And I'm not sure in those cases as a result what the patient is paying is going down. To be clear, I don't have conviction that the current system is the right system, but I do think there are trade-offs here.
Yeah, I would question why we are putting people in the position of having out-of-pocket exposure to appropriately prescribed medication, right? There's no moral hazard with chemotherapy.
And I think that's absolutely
asthma
right.
inhalers.
And I think that's why, in my view, I think often the solution is simply to regulate the ultimate insurance contract and say, listen, these are drugs we know patients need access to, and this is the max dollar amount of cost sharing that can apply. Particularly, frankly, to generic drugs where there's very little risk of.
It's a good idea. Democrats did it last Congress with the $2,000 out-of-pocket cap. Regretfully, no Republican joined us in it. Continuing your point on competition, biosimilar market is not working quite as well as we want it to. We really want to get that competition to drive down the price of these large molecule drugs because they stay expensive a long time. Again, we have seen rebates play a really nefarious role here, Humira and other examples where the PBMs are using a dual pricing structure. How can an embrace of rebates coincide with wanting a more competitive biosimilar market when they're clearly using rebates to lock in the higher priced brand drug?
So I think whether it's a rebate or there are other forms of discounts, it's going to always be in the manufacturer's interest to try to keep that biosimilar out of the market. And I think the challenge is because in many cases...
Yes, but rebates are the tool that is being used in this tango between the PBMs and pharma to do it.
And I think
let's take it away.
My contention would be that you would have other tools emerge fairly quickly.
So I want to close on that point because you talk also in your written testimony about admin fees and that, you squeeze the balloon in one place and it pops out someplace else. Again, I'm not really willing to see that point. Like our job here in Congress is like just pop the balloon. And to your point, Mr. Greminger, about the group purchasing organizations, they are one of the two places where the PBMs are already pointing to that they're going to inflate the balloon elsewhere. One is these GPO fees, which the PFB legislation will help us get ahead of it, but my goodness, Congress needs to focus on this, because I don't know what they're doing in Ireland and Switzerland, but where there is mystery, there is margin, right? And the second thing is specialty steering. I mean, you got Cigna Express Scripts CEO bragging on earnings calls about how specialty steering is their new moneymaker, and it is entirely a business, not a medical proposition here. We've got to pop that balloon, too. I yield back.
Thank you. Chair recognizes Congresswoman from Iowa, Dr. Miller Meeks, for 5 minutes.
Thank you, Mr. Chairman, and I thank the witnesses for testifying before the subcommittee today. It's no secret that PBM middlemen artificially inflate the cost of and limit access to prescription drugs. This occurs at the expense of patients who receive health insurance in public and private markets and impacts patients of all ages. The PBM market has become highly consolidated, with the three largest PBMs controlling roughly 80% of prescriptions. The top 6 PBMs account for about 97%, and in Medicare Part D, 4 PBMs manage benefits for a combined 90% of beneficiaries. PBMs claim they reduce prices by holding pharmaceutical companies accountable. This is done, they contend, by requiring rebates on drugs, which are then passed on to the beneficiary. While PBMs often do negotiate discounts for manufacturers, patients are not the ones who benefit from them. In Medicare Part D, for example, patient cost sharing is based off the list price of drugs, which are artificially inflated to extract a higher rebate. As a result of these practices, for 79 of the 100 most rebated drugs in Medicare Part D, beneficiaries pay more for their drug than their insurer, again demonstrating that beneficiaries, in this case seniors, are not benefiting from the rebates. This is why I led the bipartisan Share the Savings with Seniors Act, which would require full rebate pass-through for chronic care drugs under the Medicare Part D plans. And that's not the first time I tried to do PBM reform. My first effort at PBM reform came as a state senator in 2019, where I passed PBM reform on transparency, but could not get a pass-through of 51% of the rebates. The insurance companies were against me, my manufacturers were against me, as it was alluded to them that drug prices would rise and people would use brand name drugs rather than generics. So I've been at this now for 6 years. And when I was in Iowa last week, I read, despite all of the hurdles I had, PBM saves county money. The county adjacent to my district saves $60,000 of their county expenses with PBM reform, and now states are doing it. This isn't a partisan issue. We have over 200 pharmacies have closed in Iowa since 2014, which includes not only independent locations, but chain pharmacies such as our Hy-Vee pharmacy, and we know the bigger pharmacy chains are also closing. I'm very proud of the bipartisan work this committee has done to move on meaningful PBM reform legislation through regular order. Last Congress, the Energy and Commerce Committee successfully moved 3 major PBM policies: Medicare Part D delinking, commercial market transparency, and banning spread pricing in Medicaid. And I've done the same thing in the commercial market with the Drug Act. Mr. Grimminger, we hear from insurers and PBMs that implementing delinking won't have any meaningful action on reducing patients' out-of-pocket costs in the commercial market. However, we know that commercially insured patients are largely more exposed to list prices through larger deductibles than patients in Medicare Part D. In fact, in 2024, the average annual individual deductible for employer-sponsored health insurance was $1,787, while the maximum annual individual deductible in Part D could not exceed $545. Do you believe that if we move to regulate delinking in the commercial market, such as my bill, the Drug Act, would do, would that reduce patient out-of-pocket cost?
In short, yes. The National Alliance supports actually applying delinking to the commercial market. As you know, right now, the bill that was considered in December only applies it in the Medicare market. There's no question it takes away a financial incentive that's currently built into the program, and I absolutely believe that doing it in the commercial market will ultimately lead, in relatively straight order, to lower out-of-pocket costs for consumers.
Mr. Clancy, I'm going to ask you a question, but I want to dedicate this question to John and Jane Nicholson, who run the Mahaska Drug Family Pharmacy in Oskaloosa, Iowa, which is teetering on closing. It's my understanding that Caremark, one of the 3 big PBMs that controls 80% of all prescriptions in the country, has a request for proposal out to pharmacies asking them to do 2 things. And sometimes this information and contracts are sent by fax, which most people don't utilize. So in order to be considered part of the network of covered pharmacies in their Medicare prescription drug plans, 1, offer an amount of reimbursement that is below what it costs a pharmacy to acquire and dispense medicines. Force pharmacies to select which of their competitors Caremark should remove from the network, a blatant disregard of Medicare Part D's any willing provider requirements for pharmacy, which state that any pharmacy that agrees to a Part D plan's standard contract terms and conditions must be allowed to participate in the plan's network. Is it not the exact type of anti-competitive behavior everyone has been pointing to for years now? And does it demonstrate why we need stronger protections for all pharmacies serving seniors and Medicare, not just those owned by PBMs?
I very much agree. And in Georgia, Caremark covers our state health benefit plan. And I ran my reports before I came, and 24% of the prescriptions I dispense, I get reimbursed below my cost of purchasing the drug. 75% of the prescriptions that I fill are below my cost of doing business. So 25% is actually my gross profit scripts.
Thank you so much. I yield back.
Thank you. Chair recognizes the Congress lady from New York, Ms. Ocasio-Cortez, for 5 minutes.
Thank you so much, Mr. Chairman. No, I think that in a political environment that we're in right now, it's actually just a tremendous glimmer of hope that people can have in seeing that there are areas in which we can agree. And PBMs are a perfect example in which everyday Americans who live in rural areas, who live in urban areas, working people are getting totally squeezed by essentially this middleman where their costs are being totally driven up, that their prescription prices are being totally driven up. And for once, we have Republicans who are championing this legislation and tackling lowering these costs, Democrats who are on board with this. And I can tell you, should this legislation come to the floor, this Republican majority has my vote. You have my vote on this, and you have the vote of many Democrats on this. Now, we've had this for some time, as what has been mentioned. Last Congress, Republicans and Democrats worked together to draft bipartisan legislation on PBMs. And one provision that made it into the December 17th, 2024 continuing resolution demonstrated how we can work together to rein in PBMs and lower drug costs for patients. We've seen how this can work, and this is a bipartisan measure that can propose more oversight of the PBM marketplace. Dr. Fiedler, can you explain how greater oversight can, in this circumstance, can help lower costs for everyday Americans?
So I think the most promising change from my perspective is the proposals to expand transparency, which I think would help PBM's clients get a better deal from PBMs. You know, this is probably most important for employers, and my view is that over the long run, employers would pass some of those savings along as wages, lower premiums, or better benefits.
And we've seen this at work even, you know, with hospital provisions forcing a little bit more transparency. We've seen costs go down when there's actual disclosure around what is going into these prices. Now, this bill was almost passed on December 17th within a bigger package to prevent the government shutting down. It has all of our support. For folks following at home, Democrats supported it, Republicans supported it. So why isn't this moving? It's not because there's no substance for it. All four witnesses testifying today are in support of it. Republicans are in support, Democrats are in support. So what happened? Well, on December 17th at 4:15 in the morning, Elon Musk began firing off a barrage of social media posts opposing pharmacy benefit manager reform, PBM reform. And all of a sudden, this bill that had almost unanimous support fell apart in a matter of hours. And the vote was postponed on that day. After he tweets, it gets canceled. Elon Musk tweets, we have nearly 435 members of Congress all on board of it. He sends one tweet, and all of a sudden, everyone backs off. And it kills drug pricing reform that saves people money on their insulin, on their asthma inhalers, on everything that they need. And then, to kick it off, 5 days after he kills pharmacy benefit manager reform, we get this tweet from Elon Musk. What is a pharmacy benefit manager?
This was at 1:02 a.m. on December 31st of 2024, 5 days or so, a couple days after he kills the bill. So the problem here is not a substance issue. It's not a process issue. It's an oligarchy issue. It's a power issue. And this room is where the power of the people of the United States reside. Whether you're a Democrat or you're a Republican, everyone here was elected to be accountable to the people of the United States, not to be governed by tweet, but to be governed by their duly elected representation. And so we can get this done because there are more of us than there are of him. So I would love a commitment from our Republican counterparts who we agree with on this issue to just put it on the floor and let us vote for it where there is bipartisan agreement and we can actually get a result of for the American people by booting this guy out from political influence. And with that, I yield back.
Thank you. The chair recognizes himself for 5 minutes of questions. My state of Oregon ranks second to last in the country for access to retail pharmacies. This is a problem that is not going away. It was reported that in 2024, 36 pharmacies closed their doors. This shortage, like almost every other healthcare shortage, is more acute in rural areas where often only a small number of pharmacies serve an extremely large area. My district, for example, is larger than the state of Washington, and we've been losing pharmacies, and it's leaving communities in desperate straits. Mr. Wright, can you speak to how consolidation in the PBM market and PBM business practices are impacting access to pharmacies in rural areas?
Thank you for the question. I think the issue of consolidation, we talked about the three major PBMs that control 80% of the market, but I'd also like to stress not just the consolidation both vertically and horizontally. The ability of the integration between insurers, PBMs, and pharmacies means that there is a perverse incentive and a misaligned incentive for PBMs to favor the pharmacy chain that they happen to own, which is maybe unrelated to cost, quality, convenience, customer service, or any of the things that we would want good purchasing to be based on. It's appropriate to negotiate over those factors. It's not appropriate to negotiate or to be undercut by the fact that you're members of the same ownership group.
As long as I'm asking you questions, who actually benefits from the rebate?
Well, to the extent that the rebate system creates an incentive for higher list prices, then that's a detriment to all of us who pay the price, whether it's patients, payers, employers, union trusts, or anyone. To the extent that the rebate does go to at least to the payer, although we don't necessarily know exactly what those rebates are, and that's one of the reasons why the transparency legislation is so important.
And going to that transparency piece, you would think what would happen as a result of total transparency? What's the good that comes from it?
Well, I think that the main point would be that both patients, but in particular the plans, the purchasers, the payers, would have a better idea of to see if the PBM is negotiating on their behalf for the best cost and quality to be passed through, or to get a bigger rebate on behalf of the PBM. And that's the misaligned incentive that right now we have. It's an opaque situation.
Dr. Chansey, your family has operated an independent pharmacy for 3 generations. Some say that PBMs aren't to blame for the closures of these pharmacies, and some allege that the new generation is simply incapable or not wanting to carry on the business. I find that not convincing. What's your thought?
I totally disagree. The PBMs are directly related to our unfair reimbursement, and some of the tricks and the games that they play are killing independent community pharmacy. As I shared earlier, we lost 450 since June of 23. And when you lose an independent pharmacy in an area, no one's rushing back in to replace them. So you're not just losing a drug distribution point, you're losing a healthcare provider. And in 6 counties in Georgia, that is the only healthcare provider in those counties. So it's a critical situation.
Yeah, but your opinion, what's going to fix it? Because I represent many, many, many small communities, and they're losing their pharmacies. What's the best thing we could do here to help?
Well, I think the Chairman Carter's Transparency Act and the No PBM bill that you guys have worked on is a great start. That's going to impact 55% of the business that the average independent does. It's going to do away with the spread pricing. It's going to increase transparency. It's going to have a fair reimbursement model. And we're going to encourage CMS to put in language that's going to be relevant and reasonable contract language so between the PBMs and the pharmacies.
What would the next step be?
Pass this legislation.
I'm talking about after we pass it. I'm not optimistic sort. Is there something next that you would like us to do?
Well, I think the next we need to tackle the commercial market.
Thank you. I want to thank the witnesses. Where is am I going to close out this? No, we've got another person. Sorry. Oh, I'm sorry. Apologize for that. Chair recognizes Congressman Vesey for 5 minutes.
Thank you, Mr. Chairman, and I want to thank the witnesses for being here today. And like some of the other members have already stated, we had a great opportunity last year to really put in some good bipartisan PBM reforms, but for whatever reason, my Republican colleagues caved to the president of many large companies here in the U.S. and the world. Everyone knows who the president of those companies are. That's Elon Musk. And President Elon Musk tweeted his disapproval, and suddenly Republicans who have been negotiating in good faith decided that they were just going to walk away because President Musk said that we shouldn't stand up for the American people. And so we backed down. And it's really sad because there are a lot of patients around this country that are really counting on us to do something about this issue. And so, Dr. Fielder, let me ask you, if Republicans had kept their word and passed these bipartisan PBM reforms last year, would they have helped reduce the high cost of prescription drugs for Americans, even if it were just a first step?
I think these reforms would have reduced the cost of PBM services, and in many cases, that would have translated into savings for consumers in the form of premiums and potentially, in some cases, at the pharmacy counter as well.
Yeah, no, thank you very much. And look, I want to be clear. I support the PBM reforms, but let's not pretend that this hearing is about helping patients, because it's not. It's about Republicans trying to distract from the real agenda, and that's getting health care for millions of Americans so they can hand out more tax breaks to super rich people around the country. And again, that's sad. Last night, Republicans passed tax cuts that will threaten the health care for more than 80 million Americans who rely on Medicaid and CHIP. And so to put that in perspective, Medicaid covers about 40% of all births in this country and nearly 40% of all children who get their health care through Medicaid. In my home state of Texas, 1 in 3 children and 1 in 2 pregnant mothers rely on these services through Medicaid. And I really worry because in the district that I represent, I have one of the highest maternal mortality health rates in the entire country. And we need to really take this seriously. And so for Mr. Wright, I wanted to ask, if Republicans succeed in this reckless effort to gut Medicaid, what will that mean for the lives of mothers, newborn, and children who depend on this care? And what happens when access to prenatal care disappears, when kids can't get the medications they need, and when families are left without options?
Thank you, Congressman. I think you're right that we are in the middle of a maternal mortality crisis, and just to be plain spoken, that means an unacceptable rate of deaths of both moms and of infants. And there's no better way to do an investment to deal with that issue than in Medicaid. There's no bigger threat to the to that issue if Medicaid is cut severely, since it is such an important source of funding for maternity wards, for prenatal care, for postpartum care, and for children in those early development stages, and through their school careers, whether it's the identification of learning disabilities and the ability for them to get in school and stay in school, whether it's the ability of those families to be financially whole and not face, be one emergency away from financial ruin. So these are very core programs, and again, these are, and it has an impact on obviously those folks who have Medicaid coverage, but for a lot of, but it has ripple effects through the healthcare system that we all depend on as well.
Yeah, and and I don't want to get off topic here, but with so much of the country really focused on immigration issues, and we never talk about how the fertility rates in this country have played a role in that. I don't know why people would want to make these maternal mortality rates even higher by not doing something like tackling some of these PBM reforms. And again, taking the word from President Elon Musk, that is the president of several companies. I don't understand why we're not doing anything and standing up to these billionaires. So with that, Mr. Speaker, thank you, and I yield back the balance of my time.
The gentleman yields. The chair now recognizes the gentleman from Texas, Representative Crenshaw, for 5 minutes of questioning.
Thank you, Mr. Chair. Thank you all for being here on this important issue on PBMs. PBMs were created to control costs, but we continue to see rising drug prices and increased patient out-of-pocket expenses. Mr. Greminger, we hear a lot about the difference between list price and net price. But what's missing from that conversation is who benefits from that gap. From your perspective, are PBMs primarily acting as a cost-controlling intermediary, or have they positioned themselves as profit centers instead?
I think at this point, they're unquestionably profit centers. A high list, high rebate model tends to benefit both the PBMs and the drug makers.
Yeah, and there's an argument that the business model relies on complexity, that the more opaque pricing is, it's easier to extract revenue from multiple players. Do you think PBMs would function the same way if drug pricing were fully transparent? Would we see a fundamental shift in how they operate?
That's certainly my hope, and I think this legislation creates a foundation for that, to create a fundamental shift in the way that we price drugs in the commercial market. I think there's no question that the reason that we see both high list prices and ultimately high net costs is because of the complexity, the opacity, and the fact that the producers of drugs and the people who control the drugs are making quite a bit of money, whereas the people who are actually purchasing the drugs, employers, purchasers, working families, are paying more.
Yeah. And we know that formularies, the list of covered drugs, drive prescription drug utilization, and that PBMs have significant control over which medications patients can access. To what extent do you think rebate-driven formulary placement distorts the market, particularly when it comes to generics and biosimilar adoption?
I think there's a very heavy distortion. As we see in drug formularies pretty commonly, a higher priced, less effective or just equally effective drug placed at the base of a formulary because it's heavily rebated, because they may be able to tack on higher fees, and then ironically, patients actually have to go through some sort of medication management to sort of get through the more expensive drug before they can get access to the cheaper drug. It's implicit in the way that the model is currently built, functioning on kind of the rebate structure. There are employers that have worked to try to eliminate wasteful drugs in their formularies. They've created what's called a waste-free formulary and have seen millions of dollars in savings. It's difficult to do, and it requires a very aggressive employer who has access to their formularies and can negotiate with PBMs. In most cases, employers tend to just take the formula that they're handed to them by their PBM, which, as we know, is heavily distorted.
And PBMs argue that they use rebates to help lower overall costs, but they also choose not to cover list price alternatives such as generic and biosimilars. Can you speak to whether PBMs are truly considering patient costs or outcomes in these decisions, or if it's all financial?
I hate to comment too much on what they are intending to do, right? We know what the outcomes are. So the outcomes are certainly higher profits for the PBMs. We know that patients often are asked to pay the out-of-pocket costs associated with a higher list price or a higher price drug before they're given access to a lower cost alternative. We know that the impact of that is lower utilization, more people getting sick, people not being able to afford the drugs that they need. We heard the story at the very beginning of this about a patient who ended up in the hospital because of a change in the formulary based on a PBM. I don't want to suggest that I know what's in the heads of the folks that run PBMs, but I know that certainly the end point is higher profits for PBMs and less access for patients.
Thank you. Mr. Fiedler, there's been growing scrutiny of how PBMs interact with vertically integrated health plans and specialty pharmacies. In your view, do these integrations ultimately help patients, or are they reinforcing market dominance in ways that limit competition and drive up costs?
So at the risk of being the sort of stereotypical two-handed economist, I think there are trade-offs here. I think the concerns that they are steering business particularly to their own pharmacies, and that is over time giving them a dominant position in the pharmacy market is a real one. I think there's also opportunities to use affiliated pharmacies to skirt medical loss ratio relationships in cases where the insurer, the PBM, and the pharmacy are all part of the same entity. On the other hand, I think there are instances where it's legitimately more efficient for a PBM to deliver drugs through its own pharmacy in terms of the cost of processing claims or managing utilization. It may also allow the PBM a sort of way out around market power held by some outside pharmacies. So I think there are real trade-offs here. And honestly, from my perspective, the evidence is not clear on what the net effect is.
Okay. Appreciate that, and I yield back. Thank you.
Gentleman yields back. Chair recognizes the gentleman from Ohio, Representative Landsman, for 5 minutes of questioning on PBM reform.
Thank you, Mr. Chair. The biggest issue that we're all wrestling with, or should be wrestling with, is the cost of everything, including prescription drugs in healthcare. And in an ideal world, we get to a place where we're reducing costs and saving taxpayers money. That we're reducing the cost of, let's say, Medicare. And so with the PBM reforms, one of the bills was our bipartisan bill that would require transparency in the transactions that PBMs have with Medicare. So if they're buying at one price and selling to Medicare at another, that we have full transparency. Ultimately, that money has to go to Medicare. The savings should go to Medicare and to seniors. And it would save Medicare tens of millions of dollars, seniors ultimately tens of millions of dollars. And thanks to Chairman Carter and other Republicans on this committee and Democrats, there was an incredible package of PBM reforms. And it sat there. We talk a little bit about what happened at the end. But there was this long period of time where it was supposed to come to the floor, and it was going to be up for vote, a full vote, because it passed, as I mentioned to the chairman yesterday, because of his hard work. And I mean this. He is so passionate about this and an incredible leader on these reforms, which will save people tons of money and will save taxpayer money. That it sat, in this Congress for, 6, 7, 8 months. And people watching at home should know that we come up here every week. We vote for 4 days. We vote on like 3 bills, even though when we went on break for the election, I looked it up. There were 698 bills that had passed out of committee, including all of the PBM reforms. So why didn't it come to the floor? They get it in the final package, the final spending package, and then yes, Elon Musk says, I don't like it. He raises the question, what is a PBM? It's a middleman. It's the companies that buy and sell prescription drugs on behalf of providers, including Medicare. And it gets cut. And so we can blame Musk, but it was also the speaker and others who said we're going to take it out of the bill. And my frustration is, because this is a hearing on PBM reform, is this larger issue with committees, including this one, and incredible work from the chairman and others, and it just never goes to the floor. The one big thing that we passed last year at the end of the year was the Social Security Fairness Act, because we forced a vote. We had to force a vote with a discharge petition. And so I know that Ms. DeGette mentioned the idea of a suspension vote. I would also argue that a discharge petition, whatever it takes, we have so much compelling evidence that these reforms will fundamentally improve people's lives. It will save people money at a time when people are struggling to pay their bills, including the cost of healthcare and prescription drugs. Why wait another day? Put the package back together, put it on the floor, force a vote if we have to. But I think that's where we are, so that nobody can stand in the way and say, well, this guy didn't like it, or maybe next time. It's just, I do believe that this is one of those moments where the policy is right. People are desperately in need of help, and we should do everything in our power to get this thing done. And I stand with the chairman and the ranking member in making sure that we're doing everything in our power. I will say in my final minutes or seconds that Mr. Pallone makes a very important point, which has been brought up many, many times, which is even if we pass we have to pass the PBM reform. But it will only help people who have health care. And if this body decides that it's going to take health care away from millions of people in order to pay for tax cuts for big corporations and billionaires, they have failed. And so we have to do everything in our power to make sure that doesn't happen, that we get the PBM reforms done, and we ensure that there isn't a single dollar cut to people's health care. Thank you, and I yield back.
The gentleman yields. The chair now recognizes the gentleman from Michigan, Representative James, for 5 minutes of questioning.
Thank you, Mr. Chairman. Something actually just came back, which is germane to this conversation. I'd actually lead with this. Let me back this back up. I'm sure you'll be able to recognize the voice.
The spending bill that passed last night aims to cut $2 trillion.
Right.
Can you guarantee that Medicare, Medicaid, Social Security will not be touched?
Yeah, I mean, I have said it so many times, you shouldn't be asking me that question, okay? This will not be read my lips.
Mr. Chairman, I have to object to the playing of I have to object to this.
You have to object to the words of the president because you don't agree
No,
with
sir,
it?
I have to
I'm
object
reclaiming
to-
my time, Mr. Chairman. I'm reclaiming my time. I want to correct the record for all of my Democrat colleagues who are fear-mongering that right now the President of the United States just stated that we are not going to be touching Social Security, Medicare, Medicaid. This is directly from the President of the United States, from his lips. So what we are here to do is increase accessibility. What we're here to do is lower cost. What we're here to do is increase quality and get rid of waste, fraud, and abuse. And part of that is making sure that PBM reform comes. I appreciate the opportunity to speak and dispel the rumors and the fear-mongering, but Donald Trump's election signaled that the status quo is failing the American people. For decades, healthcare costs have soared, while access and quality have declined. Enough is enough. PBMs have been accused of exploiting opaque practices to drive up costs for Michigan families. We need reforms in order to enable transparency. In fact, the President of the United States just signed transparency reform, EO. Are you telling me right now President Biden couldn't have done that for the past 4 years? President Trump has done it in the first 60 days. And we are continuing to pass rules through the last Congress and working on this one to make sure we get PBM reform done, increasing transparency. So, in the 3 minutes that I have here, I'd like to hear from our friends across who come. Thank you for your time. A study analyzing nearly 2 million generic prescriptions dispensed to Michigan Medicaid managed care beneficiaries between Q1 2016 and Q1 2018 revealed that PBMs overcharged the state's Medicaid program by at least $64 million through spread pricing, overcharged. During this period, the spread margin on oral solid generic drugs escalated from 2% to 34% of managed care costs, while pharmacy margins over the national average drug acquisition costs decreased by 50%. By Q1 2018, pharmacies were reimbursed an average of only 49 cents above NADAC per prescription, equating to just 5% of Michigan's estimated $10.64 dispensing cost per prescription. These practices have raised concerns about their detrimental effects on patient access to care and the financial viability of independent pharmacies. Given this context, how have PBM practices such as spread pricing, rebate-based formularies,
patient steering to affiliated pharmacies and administrative fees impacted your ability to see patients. Mr. Grimminger, Mr. Chansey, Dr. Fiedler, Mr. Wright, thank you for your time. We have a minute and a half. If any one of you would like to jump in, I would appreciate it.
Well, I agree with you 100%. We have to stop steering, and we have to we have to have access. But as long as they continue to be able to pay themselves different than they're paying the community pharmacies, it's just an unlevel playing field, and it's not sustainable for the community pharmacies.
Thank you.
Congressman, thank you for your question. I will say that certainly I know that banning patient steering in the Medicare discussion is here. We would oppose anything that requires plan sponsors to open up their pharmacy networks and treat sort of any willing pharmacist or provide care at any willing pharmacist. We believe it's the role of plan sponsors, employers, and purchasers to identify what the lowest net cost is placed to provide whether it's care or prescription drugs. Often that is at a community pharmacy because of the distorted markets, and we see that PBMs are charging a lot more for mail-order pharmacies. But in the end, we want to make sure that we maintain that flexibility and a free market.
Thank you.
Yeah, I would align myself with Mr. Grimminger on this. But the reason we support the transparency reforms that we're talking about in this committee is because we need much more sunlight on even what these processes are, what the problems are, and what the misaligned financial incentives are that actually create all these perverse problems. But I think with that, then we can have a better ability to then have one of the Congress members mentions what's next. I think that the transparency would inform additional reform with regard to dealing with these abuses.
Thank you, Mr. Chairman. I'm out of time. I look forward to working with my colleagues on both sides of the aisle to prioritize the American people and not our own political differences. Thank you.
Thank you. Gentleman yields. The chair now recognizes the gentleman from New Jersey, Representative King. Representative King from New Jersey, for 5 minutes of questioning.
Thank you, Mr. Chairman, and thank you to our witnesses here today. I'm interested in hearing how we can change the dominant PBM model to better help patients in New Jersey and across the country. Mr. Chansey, last year, a New York Times investigation highlighted the experience of a 77-year-old New Jersey man, Joseph Kaplan, had with America's opaque pharmacy benefit system. Mr. Kaplan explained a scenario where his preferred pharmacy was integrated with a PBM, Express Scripts. They told him they could receive a 3-month supply of his drug for $186. However, after his own research, Mr. Kaplan discovered that Costco, a non-preference pharmacy, could provide the 3-month prescription for $56. Mr. Kaplan concisely described the scenario. It's just nuts. First, can you explain to us how our current system allows for such a confusing scenario for patients?
Well, I think that is we have one of our pharmacies is located next to a CVS, and many times we will not be able to fill the medications at our pharmacy. We'll have to send them to another pharmacy. As long as the PBMs are going to continue to be in the game with us, it's going to be unfair. And I'll equate it to this: it's almost like Walmart telling Target who can do business with them and what prices they can charge. That's the environment that we're in right now. And everybody would say, well, that's ludicrous. Well, that's our world. That's where we're at. Until we make some changes there, we're going to continue to have these problems.
And so how is the reform measure that we're working to get through this committee and pass the Congress on a bipartisan basis help Medicare patients like Mr. Kaplan?
Well, with transparency, start with transparency and eliminating the spread pricing. The 3-axis advisor study talks about that the PBMs are paying themselves 35 times higher than they're paying independents for prescriptions. That's ridiculous. And that's on mail order. But they're paying themselves that much more than we're getting paid in the community. Even in the state level, from the bricks and mortar stores, sometimes they will get paid $50 to $100 more on a prescription than they're paying us. And that's just, we need a level playing field. We need a fair, equitable reimbursement model, and we need transparency, and we need to eliminate the spread pricing.
Okay. And are there any other further actions as we're looking at reforming this entire ecosystem that you would encourage Congress to look at to improve our current pharmacy benefit program for patients?
I think the legislation that Representative Barger talked about earlier would address a lot of the issues that we're talking about, and look forward to that getting more progress as well.
Thank you. I now want to discuss how many PBM's current rebate model incentivizes high list prices for drugs. In this model, many drug manufacturers offer high list prices so that they can provide a greater discount demanded by their PBM through a rebate. The manufacturer does this to get a better place on an insurance plan's formulary. This can also result in less favorable formulary placement for cheaper generic drugs or biosimilars, which is concerning since these products are some of the most time-tested tools to lower drug prices through competition. Dr. Fiedler, could you explain how PBM's current practices may limit the market penetration of these FDA-approved generic and biosimilar products, and how this lack of competition affects the drug prices faced by patients?
So I think it's reasonable to worry that PBMs sometimes favor highly rebated drugs over low-priced drugs, even when that's not in the payer's interest. And I think, biosimilar entry is one place where that could have consequences. I will say that I think where this is happening, the main issue is not necessarily always self-dealing by the PBMs, but frankly, it's the manufacturer who is insisting on some of these types of arrangements that can then put both the PBM and the payer in a difficult circumstance where they've got a lot of patients on the reference product, and moving those patients over is going to be very expensive. So I think this is a place where, frankly, there's a lot of blame to go around, and the PBM's incentives can be misaligned here, but ultimately the manufacturers are, working pretty hard to protect their market position as well, and they need to be part of the conversation as well.
Okay. Thank you. I yield back.
Gentleman yields. The chair now recognizes the gentlelady from,
Massachusetts.
Massachusetts, of course.
Thank you, Mr. Chair.
Representative Trahan for 5 minutes of questioning on PBM reform.
Yes, absolutely. Thank you, Mr. Chairman. Thank you to all the witnesses today. As many of my colleagues have already stated, this committee spent the past 2 years working across the aisle to craft a bipartisan package of critical health bills, including long overdue PBM transparency reforms. After months of negotiations, careful policymaking, we put forward a package that would lower costs, increase transparency, and strengthen health care for families across the country. But one tweet from Elon Musk killed that bill because it was, in his view, too long. How embarrassing. That idea that a billionaire's unserious, offhanded social media post could derail 2 years of serious bipartisan work that would have improved healthcare access and affordability for millions, is just a shameful indictment of the way my Republican colleagues operate. One of the policies caught in the crossfire was my bill, the Accelerating Kids Access to Care Act, which would make it easier for children on Medicaid to cross state lines for life-saving care that they need without delay. That policy, a straightforward and necessary fix, was sacrificed because my Republican colleagues chose to cave to the whims of a billionaire instead of protecting vulnerable kids. And it's even more infuriating when you consider that the pay-for to support this good policy was a ban on spread pricing in Medicaid, a practice that allows PBMs to siphon off taxpayer dollars that should be going to patient care. Let's be clear, this is part of a much larger assault on Medicaid. Just last night, with their budget resolution vote, House Republicans went on the record in favor of cutting $880 billion from Medicaid. That goes far beyond targeting waste, abuse, and fraud. Those are the cuts that will rip coverage away from families, children, postpartum moms, seniors in nursing homes, and kids with disabilities. So while we sit here talking about PBM transparency and Medicaid reform, let's not lose sight of the bigger picture here. There are people in this room who just voted to gut the very program that they claim to want to strengthen. Just unacceptable. And I know I will be joined with my colleagues on this side of the aisle. We won't stop fighting to protect the kids and families who rely on Medicaid for their care. And while I'm pleased that strengthening Medicaid to help kids cross state lines more easily has bipartisan support, I'm concerned with the deep cuts to the program and how they will undermine its impact if states are forced to scale back their Medicaid programs. This policy would become meaningless. Dr. Fiedler, as we've seen with last night's budget resolution vote, House Republicans are pushing for nearly $880 billion in Medicaid cuts. If these cuts go through, what would that mean for families already struggling to access care?
Broadly, you're going to see states facing two hard choices, right? They can either raise taxes and cut elsewhere in their budget, whether it's education or transportation or public safety, or they can say, we're going to cut our Medicaid programs. And, that's going to mean their options are they can cut enrollment, they can narrow what services Medicaid covers, they can put in more utilization restrictions like prior authorization, or they can pay providers less. And all of those things we know reduce access to care, and where people are becoming uninsured, we know that impairs financial security as well. And I think this is all in a context where we know Medicaid is a fairly stingy payer, certainly relative to private insurance and typically relative to Medicare as well. And that Medicaid beneficiaries already enjoy worse access to care than people with many other forms of coverage.
Thank you. One of the policies in our bipartisan package was a ban on spread pricing in Medicaid. Can you explain how banning spread pricing could free up resources to strengthen Medicaid and in turn help policies like the Accelerating Kids Access to Care Act ensure children can cross state lines for the care that they need without delay?
So I think the hope is that banning spread pricing, reduces the cost that states are bearing in their PBM or managed care contracts. I think, I've expressed concerns elsewhere in my testimony that PBMs may try to get some of that back in other ways, but I think this is a place where, because of the medical loss ratio requirements that apply, this type of requirement may actually generate some savings for the ultimate payer, and obviously policymakers could use those funds in a variety of ways.
Thank you. At the end of the day, Medicaid is a lifeline for millions of children, families, and vulnerable Americans, and we have a responsibility to strengthen it, not dismantle it at the whim of the special interests of a billionaire. So I hope my colleagues will reconsider the harms these cuts would cause and work to help us protect and improve access to care. Thank you. I yield back.
The gentlelady yields. The chair now recognizes the gentlelady from Florida, Representative Castor, for 5 minutes of questioning on PBM reform.
Thank you very much, Mr. Chairman, and thank you to the witnesses for being here today. I strongly support PBM reform. I think it is vital and necessary and urgent. But I have to say that today families are scared and they're reeling because they know what is coming. We had a debate yesterday in this committee for about 12 hours as they debated on the floor of the House as Republicans march forward with drastic cuts to the health and well-being of families across this country. Medicaid health services are in the bullseye. The Medicaid, of course, is the largest provider of health services for children, for all of our neighbors with disabilities or complex conditions, for our older neighbors in long-term care. And why gut this and rip coverage away? To provide tax cuts to the wealthiest people in this country. It's just really hard to hear this debate because I don't think this should be much of a debate. They're saying is that this committee will come back in a couple weeks and try to take out $880 billion from the health of our families. That's going to hurt kids. And frankly, when all of us hope that, I hear from my community pharmacist, and they're on a shoestring, and this all comes on the heels of what we saw happen at the end of last year because we had worked so hard on this bipartisan package. And what happens, and I know you've heard it from a number of my colleagues today, but it's just simply not acceptable to allow Elon Musk to come in at the 11th hour and throw a wrench into our bipartisan work that would have reined in the PBMs and
and said we need more transparency, we need more Part D delinking, we need a ban on spread pricing. And unfortunately, the House Republicans reneged on the agreement. So you can see why we're kind of exercised today, why we are so concerned about it. But I'm particularly concerned about what this means for the health of a nation when you start to say to children and families that you're not going to be able to see the doctor that you need and get the care that you need. This is so fiscally unwise, too, because it's pretty inexpensive to take care of a child, early and provide the health care that they need. And don't just take it from me, take it from the independent Congressional Budget Office. They say childhood health coverage leads to higher future earnings and more productivity. This is why all Americans should be concerned about the gutting of this important pillar of the health of the nation. Because when you start to deny children access to the doctor's office and early wellness, that means that they're not going to be as successful in life. CBO says that outside of the financial benefits, the positive effects of health care are extensive. Mr. Wright, is it smart and fiscally wise to not to provide health care to America's kids? And what do you think is coming?
I mean, there's several economic impacts. If we're talking about the economics, there's several economic impacts to these cuts. There's ones of just to the community as a whole. Hospitals, health systems are typically the largest employer in the community. If you make these cuts, it has that impact and a particular multiplier effect because money spent in a community has a multiplier effect. Healthcare is not something you can outsource. It's in the community, it circulates in the community. A cut would have a redounding effect in that community economically. To those individual families, obviously, as Mr. Fiedler said, the part of healthcare coverage is about making sure people have access to care, but partially is keeping the family financially whole and not facing huge bills that come with everything from childbirth to chronic conditions to an emergency.
And the cost of living certainly is a primary issue in the lives of Americans right now.
That's right. And
is targeting Medicaid to give tax breaks to billionaires going to help the average person?
I mean, the loss that people will have individually will be much greater because of the financial instability that comes with not having health coverage.
I agree. Thank you very much.
Thank you.
The gentlelady yields. I believe that is it for questioning today. I want to thank all of our witnesses again for being here today. Members may have additional written questions for y'all. I'll remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond to the questions promptly. Members should submit their questions by the close of business on March 12th. I also ask unanimous consent to insert in the record the documents included on the staff hearing documents list. Without objection, that will be the order. And without objection, the subcommittee is adjourned.